Hi guys, this is Dr. Marwah, and today I'll be taking your session, which is gonna be a mock session to check out your preparation for the exam. This would help you analyze your skills when it comes to ruling out the options in the MCQ. And what I would like you to do is, since you have made all the effort of coming and joining this session, so my suggestion to you would be that just keep a note of how many have you attempted with me and how many of these did you get correct, and especially focus on those topics which actually went wrong, because the ones that are going wrong, you need to go back to go back to those topics in either the rapid revision or maybe the main section of the videos, depending on the level of criticality of error. If it was a simple, I mean, because we are discussing previous year questions and ideally PYQs should not go wrong. So in case they go wrong, you need to go into a fault finding today, which is going to be that was it a silly mistake or was it lack of knowledge. If it's a silly mistake, I think just going back to the rapid revision would be more than sufficient. But if it was lack of knowledge and you messed up big time on that question, then my suggestion would be to go back to the main video and have a look at what really went wrong. So very good evening to everybody, and I think we're good to go. uh, Starting with the very first question for today. Yep, Sandeep, thank you so much. Hi, Vikas. Then Prithvi, Shefali, Mohammad Shahzad. So I think I missed a couple of names. Due apologies for the same. And this would be a pure FMG centric discussion. Yes, Komal, Nikki, then Alam, Sunil, Anup, Bablu. So great, guys. Good. I think we're good to go for this session. नथिंग इज सफिशिएंट भाई, हैरिसन भी सफिशिएंट नहीं है तो जो लोग पढ़ लेते हैं अच्छे से 2-3 बारी, उनके लिए सफिशिएंट हो जाती है, समझ के पढ़ना होता है. वेरी गुड इवनिंग. Starting with a 30-year-old man who is on bed rest after fracture of bilateral tibia 10 days ago. Maybe this guy was crossing the road and there was a car accident, and he ended up with a pretty nasty bilateral tibia fracture. Okay, good. I'm getting good answers now. Initially, I was getting B and a D. So let me just explain this. We are having a man who's had a fracture of the tibia, and then he's after 10 days, he's suffering from breathlessness and chest pain, and the congested neck veins present in this patient. So considering the fact that there is immobilization in a patient after orthopedic fracture, there is a immobilization. The chances of stasis of blood in the calf veins is very high. This is a two-step question. He's first asking you what is the diagnosis, and then he's asking you how would you be working it up. The clinical diagnosis of this patient is not fat embolism, as is the initial impression that couple of guys are jumping into. Considering the fact that this is a PYQ, my suggestion to you guys would be that PYQs गलत नहीं होने चाहिए, उसमें 100% स्ट्राइक रेट रखना है, क्योंकि नया क्वेश्चन आता है when it's a relatively new question with some new kind of information introduced. I can understand that some error of judgment or evaluation in the MCQ is possible, but in a PYQ I don't think so. There is any valid reason that it can go wrong, and that's our objective, to ensure that आपके जो PYQs हैं उनका 100% स्ट्राइक रेट रहे. तो जब भी there's a immobilization in a patient, whether it's due to orthopedic reasons or non-orthopedic reasons, it really does not matter. There would be a pulmonary thromboembolism developing in a patient, because of which there is a big clot blocking the pulmonary artery of the patient. And how do I know that there is some problem in the pulmonary artery of the patient? He's talking about congested neck veins in this patient, because pulmonary artery, if it is going to be suddenly blocked by a big clot or multiple clots, there is going to be a right ventricular failure, which will explain the elevated JVP in this patient. We do not read about right ventricular failure findings in a patient who's suffering from fat embolism. So yeah, I think a lot of people were initially thinking it's fat embolism considering an orthopedic fracture, but as I've sensitized you multiple times, every time you are having the points in favor of the diagnosis are: one is immobilization of a patient, the second is going to be finding of right ventricular failure causing an elevated JVP. So if you put the entire thing in the right perspective, the diagnosis of this patient is pulmonary thromboembolism, and the best to confirm the diagnosis of this condition would be a CT angiography. ECG, well, I can do a ECG in this patient, but it will not show very conclusive evidence, because there can be two possibilities. Either the patient, if he's having a pulmonary embolism of the submassive variety, then there could only be a sinus tachycardia, or otherwise there would be a very classical finding that's called as S1Q3T3, that's deep S waves in lead 1, deep Q waves in lead 3, and then T wave inversion in lead 3. But that's not very classical, because ECG is never diagnostic for any patient with pulmonary embolism. And when it comes to echocardiography will tell me about the right ventricular hypokinesia present in this patient. In fact, it gives me an opportunity to discuss one more MCQ of your FMG exam, the radiology question, which was with respect to McConnell sign. The question was like, McConnell sign would be seen with respect to which condition? The answer is pulmonary embolism. That's because there is a blockage of the pulmonary artery, and as a result of it, there would be a interventricular septal defect, there would be interventricular septal deviation in fact, and there would be a right ventricular hypokinesia. तो जो correct answer is question का वो answer an option question number 1 का, that is option number D. Hi to everybody who said in between, maybe I missed out a couple of names. Do apologies for that. Yep, D dimer clots की formation के बारे में बताता है. So because there's gonna be clots, so if the question says screening test for this condition, then the answer is D dimer. तो एक बार रिवाइज कर लेते हैं. मैंने फर्स्ट क्वेश्चन में 3 MCQs डिस्कस किए हैं. The 3 aspects to be understood are, number 1, एवरी टाइम दे गिव यू, जानबूझ के वो ऐसा साउंड करेगा जैसे, क्योंकि ही विल टॉक अबाउट एन ऑर्थोपेडिक फ्रैक्चर, और जरूरी नहीं कि ऑर्थोपेडिक फ्रैक्चर की बात करें. ही कैन टॉक अबाउट अ जॉइंट रिप्लेसमेंट सर्जरी इन अ पेशेंट. ही कुड से पेशेंट अंडरवेंट अ THR, पेशेंट वेंट अ टोटल नी रिप्लेसमेंट, एंड आफ्टर अ THR और मे बी आफ्टर अ TKR, आफ्टर अ टोटल हिप रिप्लेसमेंट और आफ्टर अ टोटल knee replacement, there is gonna be formation of clots in the pulmonary artery of the patient, and that could result in this patient deteriorating. So don't focus only on the long bone fracture, focus on the entire domain of the question. And the biggest point against the diagnosis of fat embolism in this question is elevated JVP, which we do not read about. More importantly, for diagnosis of fat embolism, you need to remember GERD criteria. तो पहला point तो खैर pulmonary thromboembolism का diagnosis is the important part. That's the first message. Second thing that you need to remember for this question is a radiology question. McConnell sign is seen in, that would again be a patient of pulmonary embolism. Then is a screening test for this condition, that is D dimer assay. D dimer is gonna be positive in any hypercoagulable state. Even in COVID, you know, we were writing D dimer for our patients because COVID is also a hypercoagulable state. So Gautam, I'm perfectly fine. Thank you so much for joining this discussion. And GERD criteria, well, GERD criteria may 3 things are very important. There should either be a lung involvement, or there should be a brain involvement, and there should be petechiae occurring in a patient, usually starting in the axilla and involving the chest wall. So at least go through the major criteria, the major GERD criteria for diagnosis. Lung involvement would mean respiratory distress. CNS involvement would be in the form of coma in a patient, and then there's going to be rash starting from the axilla involving the chest wall in the patient. So GERD criteria have to be deployed for diagnosis of fat embolism. Not present here, no radiological findings in favor of it. In fact, there's a right ventricular failure which goes against fat embolism per se. So I think we can solve this one. So answer to 1 is Delta. Hi Mayur. We start with the second one. This is a smoker male who's presented with cough for last 2 months, and he's recently also suffered or developed a hoarseness of voice. Since the question is talking about a smoker and then is talking about cough, so I'm thinking possibly either it would be COPD in a patient, or it would be a malignancy as well. So let's evaluate. Subsequently, he says there are congested neck veins and superficial veins of the chest wall also. And moreover, there's a cavity in the right upper lobe of this patient. So I think I can wait for a couple of answers in this particular case, especially with respect to cavitation present in this patient. Okay, so I think we'll be doing 50 and I expect you to be, ideally I would have loved to do 50 minutes, but then it's not possible to do them so fast because I need to explain them also. So I would like you to see or analyze subsequently and comment in the chat box later, and be honest for that. Comment in the chat box about how many did you get correct out of 50, and I expect a 100% strike rate here. Okay guys, let's roll. A 50-year-old patient, he's a smoker, he's a male patient presenting for cough for last 2 months and recently developed hoarseness of voice. And the most important thing in this question is that whatever is present with which is causing cough is also causing compression of certain structures, because you can see it's written congested neck veins and superficial veins of the chest. So in all due probability, this patient is having compression of the superior vena cava. because there's a superior vena cava syndrome manifestation given in this question, which is with respect to congested neck veins, superficial veins in the chest wall. There has to be a mass which is probably pressing on the superior vena cava of the patient. You are aware of the fact that all lung cancers that begin with alphabet S are related to cigarette smoking, and all lung cancers that begin with alphabet S are also central in location. So what I am thinking in this particular question is that there is some kind of a malignancy which is central in location, which is pressing on the superior vena cava. It can't be more obvious than that. And moreover, the speciality of this malignancy is that it also causes another C, that is a cavitation. See, a lot of people initially answered lung abscess. So lung abscess में तो there should be a presence of high grade fever with chills and rigors, which is not given in this case. Plus the sputum is gonna be horribly smelling. I mean, there was no description of any purulent sputum in this patient. Pulmonary tuberculosis is common in India, but TB to cause a mass effect causing congested neck veins, chest wall is relatively unlikely. So I can rule out two options here right away. Lung abscess ruled out, no high grade fever, chills, rigors, no scenario for lung abscess given. Pulmonary TB ruled out because there's no low grade fever, evening riser temperature, night sweats, hemoptysis described in a question. So I am here gonna think in terms of a malignancy itself. And between the two scenarios, I mean, the option number B is something that can be ruled out relatively easily. I mean, lung cancer is gonna be the presentation that's gonna result in this SVC syndrome and not a carcinoma larynx. The correct answer for this would be option number A. Yes, doctor. Squamous cell cancer will contribute to a cavity formation as well. That's perfectly right, Raj. That is what I've said, and that's what's happening in this patient also. There's a cavitation in the right upper lobe. There's a mass which is also having auto destruction, as I can call it, the central part of the, because the cancer is growing rapidly. So some part of the cancer is outgrowing its blood supply, because of which the death of the cancer can contribute to a cavitation as well. The correct answer for this one is option number A. Considering smoking given in a question, considering cough for two months in a patient, it's unlikely to be COPD. I mean, COPD will have history over large number of years, and this would be a relatively shorter history. But yeah, and on a comparison basis, I can say that between carcinoma larynx and squamous cell cancer, option number A would be the best bet to solve this question. So good job. I think a lot of guys have scored pretty correctly in question number 1 as well as in question number 2. Hi Gurmeet, good to see you again. And we move on to question number 3. He says, in a patient with bulbar palsy. Bulbar palsy basically means involvement of the brainstem from which cranial nerves are originating. So bulbar palsy basically means lower motor neuron lesion of the cranial nerves. Now there are multiple cranial nerves originating from the base of the brain, but he's basically asking regarding I mean, if you look at the manifestations, everything is having the word tongue written. So he's basically trying to test me with respect to lower motor neuron lesion of the 12th nerve. And this is an anatomy/medicine based question, that in a person who's having a lower motor neuron lesion, you are going to be having a tongue deviation to the same side. That's a ipsilateral deviation. Again, a very spot on, and I got very good answers there. Answer to question number 3 is Bombay. And in case it was written pseudobulbar palsy, pseudobulbar palsy would be in upper motor neuron lesion. And in case he give you a situation like this in which there's a pseudobulbar palsy occurring in a patient with respect to the 12th nerve in a patient, then it is the involvement of the corticobulbar fibers. The answer to this one is B. That's perfectly fine. But if he talks about corticobulbar palsy with respect to the 12th nerve, then it's the corticobulbar fibers that would be involved. And the manifestations in this patient would be a spastic tongue, and the patient will not be able to take that tongue out of the mouth. Since there's a spastic tongue, there would be inability for the patient to rather take the tongue out of the mouth, unlike a lower motor neuron or a bulbar palsy where he can protrude the tongue, but the tongue deviation occurs to the same side. So the correct answer for this one is beta. But then in case he talks about a spastic tongue, that's gonna be a pseudobulbar palsy related to the 12th nerve. We are sorted for the third one. Let's move to the fourth one for today. Again, a repeat one, JVP. I think the table is very self-explanatory in both RR as well as in the main videos. So it's a suggestion. Yep, it would be a contralateral involvement. Hi, Dr. Rathore. How are you? Let's focus on the question at hand. Giant V wave in the JVP would be seen in which of the following conditions? And yep, exactly. Giant V wave would imply that after C wave, there would be actually the technical question for this is CV wave. And instead of saying a CV wave, the question was put up as, hello, Dr. Chaudhary. Yes. No, there would be no new addition coming up. There's too lesser time. So please focus on the addition that you have and try to do that particular question. I'll just do a quick diagram for this condition, though I think I've had a correct answer. So let's do this in 30 seconds. We'll first draw a X descent. So, I mean, in case you're getting it incorrect, just try to do this with me. Every time you're going to have a ventricular systole, there's going to be blood rushing into the aorta and pulmonary artery. I'm still having 15 seconds to solve it, right? So the vector at the moment is pointing upward because of the valve. The vector at the moment is pointing downward, which is with respect to the valves going back to normal position because of the systole. And then what you're going to do in this patient is you're going to show leakage of blood like this. There's a tricuspid regurgitation. The two vectors will cancel each other. In fact, there's a possibility that if this vector is strong enough, this would cause the entire blood to move upward and the column to move upward as well. I mean, the X should have been coming as a negative, but we are getting a big positive deflection. That's called as a CV wave, and that's seen in patients of tricuspid regurgitation. The remaining options are pretty easy. I mean, patent ductus arteriosus is where we read about a continuous murmur, dilated cardiomyopathy. I think you need to remember about the pulse that we encounter here. That's called as a dicrotic pulse. And as far as aortic regurgitation is concerned, if they are anyway asked about it, then I think all of you remember regarding Austin Flint murmur. That's a mid-diastolic murmur which is encountered in patients of aortic regurgitation. So for PD, I've not written. That's pretty straightforward. Nobody has an issue with that. But do remember two more datas, very straight liner, one-liners. Dicrotic pulse is seen in dilated cardiomyopathy, and Austin Flint murmur is a mid-diastolic murmur, which would be seen in any patient who's having a severe variety of aortic regurgitation. We are sorted with question number 4 for today. Let's look at the 5th one. You would get a lot of these kind of questions where they'll ask you to interpret the CSF findings in a patient, as has been the norm in a couple of previous sessions. So I've incorporated, in fact, 5, 6, 7, 8, the total of 4 questions that I have taken up from the previous year sessions. In this particular discussion, I have tried to highlight those topics which have been frequently asked, and then subsequently I have analyzed each one of them. So starting with the first one, the patient is having a fever for last 15 days, and then there's subsequently lumbar puncture that was done because there's a neck rigidity. So the doctor has thought in terms of a meningeal irritation, and therefore meningitis is to be ruled out. In this particular case, there are mononuclear cells with CSF sugar of 50. So the sugar is less and the protein is grossly elevated. I mean, normal CSF protein is only 15 to 45 mg/%. And here in this case, you can see there's a 20x rise of proteins. In an Indian exam, every time you read about mononuclear cells present, every time you read about CSF lymphocytosis in an Indian exam. And apart from this, there is also evidence of 20 times increase in the value of proteins. Plus, more importantly, there's a history of 15 days, and he made it ultra easy for you. I mean, though all of you are brilliant guys and you picked it up, I mean, in the exam, he helped you by saying that there is a hilar lymphadenopathy and upper lobe involvement. You know, tuberculosis usually involves the upper lobe, and there can be a enlarged lymph nodes in the patient as well. So there's a dissemination that's happening, which is causing a formation of rich focus in the brain. I mean, the question is shouting that, okay, I am rich focus in the brain. And where do you get rich focus? You get that in tubercular meningitis. The correct answer for the 5th question that we're discussing for today is option number D. I had a A also coming up in the end, guys. Please remember that in case it is going to be a bacterial meningitis, the history is not going to be 15 days. Then there's going to be neutrophils that are going to be present. And more importantly, the protein elevation is not going to be. No, doctor, we do not get a lymph node enlargement. See, the point is the diagnosis is not, I'm not making a diagnosis on the basis of X-ray finding. X-ray finding is supportive. You have to interpret this report on the basis of the CSF report that is given for the patient. Yeah, the word cobweb, as Sandeep said, the cobweb coagulum report is not given. There's no cobweb coagulum given. I'll just show you a table. There's a small table that I made where I want you to go through the various components that are present with respect to the CSF findings. The diagnosis has to be made on the basis of the CSF findings. And if you go through the questions of the previous years, you will notice that he has always asked about these three possibilities. I mean, he's not going to let you go without making you diagnose acute bacterial versus tubercular versus a viral meningitis. So I think that is the main focus that I want you to work on. And in this question, there's the supportive evidence. The supportive evidence is that there is a kid and then he's having 15 days history present, and along with that the x-ray is showing a lymphadenopathy. Otherwise that lymphadenopathy or the x-ray finding is not gonna be diagnostic of meningitis. That's just a supportive evidence for tuberculosis. You need to first pick up meningitis in a patient. How are you gonna do that? It's the cells which are increased. I mean, as I said, CSF lymphocytosis in the Indian exam is always to be thought of as tubercular or viral etiology. How do you differentiate between the two? The sugar values. Sugar in this case is less. Normally जो sugar होता है, I think I can just invest another 30 seconds into it. Normally जो CSF sugar का value होता है, that will always be at least 2/3 or more than 2/3 of the blood sugar. So if your blood sugar at the moment is 100, then the CSF sugar should be more than 66. But in this case, it is only 50%. So we'll say that, yep, there is a hypoglycorrhea present in this case. I repeat that statement once again. All you need to do is check out the blood sugar and compare that with the CSF sugar of the patient. In this case, it is reduced to 50%. Normally is more than 0.66. So since the sugar is low, it again points towards a infection. And what is the infection present in this case? The proteins gross elevation plus lymphocytes, they go in favor of tubercular etiology. The correct answer for this is delta, and I think this will become more clear when you are going to go through the subsequent question also. So I put these questions in series which have been asked in 2023, 2022 and 2021. So this question that I discussed, I think this was 2023. Let's move on to a 2022 question. That is the sixth one. He said a young patient developed sudden onset fever and agitated behavior for 2 days. So one, I want you to focus that the history is only of 2 days. Previously was for 15 days. There were no meningeal signs that were noted initially. I mean, okay, fine. There could be encephalitis in a patient. EEG shows periodic focal temporal lobe spikes. Even if you don't know EEG, I'm okay about that. You can still solve this question on the basis of the subsequent information. Normally in the CSF, we have 0 to 4 lymphocytes. But in this case, the CSF count is slightly increased. He's saying that there are about 40 cells with 90% of them being lymphocytes, 10% neutrophils with elevated protein in the patient. So considering the fact that the temporal lobe of the patient is getting involved, there's an involvement of the temporal lobe he has mentioned. I mean, don't focus on you. I don't expect you to solve this question on the basis of EEG, but there is a finding given of temporal lobe involvement. Plus there are lymphocytes present. So when do you get lymphocytes predominantly? You get it either in a chronic infection or you get in a viral infection. Considering the fact that the way the question is given before you, first and the foremost thing is that you need to work out कि भाई lymphocyte कहाँ पे मिलते हैं. Lymphocyte या तो chronic infection मिलता है, chronic होता है TB. पर अगर ये tuberculosis होता तो tuberculosis वाले में फिर सिर्फ temporal lobe क्यों involve होगा? Right. So yep, doctor, all these questions are PYQs. Today we are doing only previous year questions. Our objective, Rahul, is to ensure 100% strike rate in case old questions or the previous questions are repeated. The clinical diagnosis in this case should be kept up as viral encephalitis. One of the very important causes for viral encephalitis is going to be herpes simplex. And considering that herpes would be causing this manifestation, we need to give Acyclovir for this patient. The correct answer is option number B. I mean, if you know the EEG finding, it's still okay. But then that, and why that's important? I mean, the temporal lobe involvement here important क्यों है? क्योंकि temporal lobe is the area where hippocampus will be there and the memory circuit would be there, the Papez circuit. तो viral encephalitis वाले patients को complete memory loss हो जाता है यार. I mean, if we fail to start acyclovir in these patients on time, the person would be having complete loss of memory. And that's, I mean, outrageous, no, that we have a patient with a CNS infection and he does not remember who he is, or he loses his entire, I mean, his whole entire life is erased just because we were late in starting acyclovir. So the first message is short history. You should think in terms of either a viral etiology or a bacterial etiology, not tubercular. Tubercular will always have a long-standing history. Plus there's a focal temporal lobe involvement in this chap, plus there's a lymphocytosis present. So it's a viral encephalitis, guys. Yep, Abhi, you were right in this, and the answer for this would be acyclovir. Ceftriaxone would be given for bacterial meningitis. Amphotericin B is mainly for in case it's a HIV positive patient is having cryptococcal meningitis, तो तब वहाँ पे यार अब हिंदी में करूँगा तो फिर पूरा हिंदी वाली भाषा ही हो जाएगी और उसकी वजह से बाकी लोग नाराज़ हो जाते हैं, तो थोड़ा बैलेंस क्रिएट करना पड़ता है। एम्फोटेरिसिन भी जो है वो क्रिप्टोकोकल नियोफॉर्मेंस के मेनिंजाइटिस के लिए, जहाँ पे वो एड्स पॉजिटिव पेशेंट का हमेशा डिस्क्रिप्शन देगा, तो थोड़ा सा वर्कआउट आपने करना है। एग्जैक्टली कोमल, यू राइट। एंड सेफ्ट्रैक्शन वुड बी फॉर बैक्टीरियल। मैं समरी देता हूँ इन सारे सवालों की, एक बार प्रैक्टिस कर लेते हैं। सबसे पहला लर्निंग पॉइंट आप लोगों के लिए ये है कि इंडियन एग्जाम में कभी भी CSF लिम्फोसाइटोसिस दिया होगा तो दो इटियोलॉजी सोच के चलना, या तो ट्यूबरकुलर होगा या वायरल होगा। अगर ट्यूबरकुलर होगा तो प्रोटीन्स ग्रॉसली एलिवेटेड होंगे, ग्रॉस एलिवेशन ऑफ प्रोटीन्स होगा और शुगरलेस होगी। बट इन केस वायरल होगा तो वायरल में द शुगर इज गोना बी नॉर्मल and the proteins are going to be slightly elevated. I'm repeating that again, please. The point is, every time you sit in an Indian exam and there's a CSF lymphocytosis, think either of tubercular or a viral etiology. In case it is tubercular, the sugar is going to be low, proteins are going to be super elevated. But if it's going to be viral, the sugar is going to be normal and the proteins are going to be slightly elevated. Plus, there is anyway supportive evidence given in this question with respect to duration being 15 days, hilar lymph nodes in a patient in a chest x-ray. So, a combination of all of these would help you nail the diagnosis. Doc, I am speaking in English only at the moment for benefit of all the people who are attending this. So, I just spoke hardly for 15 seconds and that's just to satisfy one doctor who requested me to do that. So, wherever I can, I'll try to be adjusting to everybody. Doc, I'm speaking in English only. Okay, moving to the sixth question. In this question, the keywords were short history. Then he's again given lymphocytes in the CSF plus a temporal lobe involvement. So that's going to go in favor of a viral etiology and this would be treated with Acyclovir. Moving to the seventh one, I mean, they've tested, as I've said, I mean, they've tested you on bacterial in 1 year. Another session, they've tested you on viral etiology, another one on tubercular etiology. So do practice that, and at least I can say tubercular meningitis is so in your face considering that long history, duration given, and the way the question is presented, and mostly it's going to be a child who's malnourished, that I don't think so that you can ever miss up on tubercular meningitis in a question. Now, yep, everybody is correct, spot on in this one. We are having fever for 4 days. Patient cannot touch neck to chest. That's nuchal rigidity. LP was done. Opening pressure is elevated. There is a white cloudy CSF with neutrophils. I mean, the moment you read about neutrophils present, sugar, look at it, only 1/4 of what it should be. If I take 60%, it was 66, but I'm saying if I take it at 60% for mathematical purposes, there's a grossly decreased CSF sugar. The proteins are elevated, almost 2x of normal. Considering short history, considering predominantly neutrophils present, we'll have to think in terms of bacterial meningitis in this patient. The correct answer for question number 7 is option number A. Yes, Gurmeet, we'll have to give ceftriaxone, vancomycin, Dexona in these patients. Dexona is mainly to increase the penetration of antibiotics and reduce the vasogenic cerebral edema. Exactly, Yashwant, as you said rightly, bacteria loves sugar to thrive. I mean, that's just a way to remember. It would not be technically right to say bacteria loves sugar, but that's just to make you understand that, okay, the sugar values are going to be dramatically reduced in a patient having a bacterial meningitis. Doc, steroids are given. Normally the teaching is don't give steroids whenever there is an infection, but there is mention of steroids before giving an antibiotic shot, and that's because of the fact that it would help in increasing the penetration of the antibiotics and reduce the concomitant cerebral edema component if present. The answer to this is option number A. And let's do one more question. I'm skipping a question there actually. And yep, I'm coming to question number 10. We'll come back to question number 9 in a while. And neutrophils is like saying hello to the bacteria. Absolutely, absolutely. That's a much better way, Komal, as you said. So I'm skipping a question and just handling another one, because this again was having a person having altered sensorium. As you can say, it's a kid, high grade fever, but it's only for 1 day. And then there's a loss of consciousness, there is pallor in this case, and there is no focal neurological deficit and hypoglycemia is present. So we also need to take into consideration from an Indian perspective, whenever there's a short history, not only a viral etiology is to be considered, that is even not only do you need to consider a viral meningitis or a viral meningoencephalitis, but you also need to take into consideration possibility of cerebral malaria in a patient. I mean, India anyway, falciparum malaria will cause complicated malaria, that is cerebral. And the key word in the question would be two of them. One is going to be the pallor, because malaria is going to cause hemolysis. So that's why the pallor part can be explained in this question. And second, the one of the biggest reason for death in these patients, the one of the important reasons, because cerebral malaria, the falciparum malaria, the parasite is gonna upgrade the consumption of sugar by the RBCs, and in fact these patients will die not only because of lactic acidosis, because the malaria infected RBCs tend to show clumping and there's a poor circulation, but they die because mainly not because of lactic acidosis or metabolic acidosis. These patients die because of hypoglycemia. I mean, imagine the amount of parasitic load present in the patient, that the parasites are upgrading the consumption of sugar by the RBCs to such a level that person's availability of sugar to the brain gets reduced, and these patients die because of hypoglycemia. So two important parameters which are present in this question, which help me go in favor of falciparum being the villain in this case, is hemolysis and hypoglycemia. Every time in an Indian exam, you get fever and you get altered sensorium, and there's a short history of 1 day or 2 days. Every time you are getting questions like these, short history of fever and altered sensorium for, let me say, 1 to 2 days, and he is asking regarding the possible differentials, then two differentials that are to be kept every time. I mean, this kind of an history is described before you: fever, altered sensorium, apart from falciparum malaria or cerebral malaria, viral meningitis or viral encephalitis should also be kept in mind. And for viral meningitis, obviously he's going to describe unique rigidity, then he's going to describe lymphocytes as I described in one of the previous questions. And more importantly, because of the lymphocytes being present, the sugar values are not going to be very dramatically reduced. They're going to be normal, and the proteins are going to be borderline elevated. I'll just show the table once again that I was showing once earlier. I mean, if you go through this in the RR component, or if you go through this in the main videos, you are bound to be having a better orientation to solving these questions. Okay. Gautam says, if there is a focal neurological deficit or absent, no, doctor, focal neurological deficit would mean something like an arm weakness or a leg weakness in a patient. So in case I'm having an arm weakness or a leg weakness, I'll favor tubercular etiology, because TB causes endarteritis. TB का जो bacteria होता है ना, that causes damage to the blood vessels, the terminal branches of blood vessels. It causes endarteritis, and it can cause a stroke manifestation in a patient as well. Yep, exactly. Patient can have seizures due to sluggish circulation of the brain in cerebral malaria, and can be having hypoglycemic seizures as well. Divyanshu says, what to do? Correct hypoglycemia, doc will not start antimicrobials. No, we'll be giving artesunate to the patient, and along with that we can give 10% dextrose, so that the 10% dextrose will take care of the hypoglycemia component of the patient. If it is dangerously low and you're getting outrageously low values on a glucometer of 20-30 mg/cent, you can give a bolus of 25 to 50% dextrose. Otherwise, it is artesunate and 10% dextrose that should stabilize the sugar values in this patient. Okay, moving to the next question, in which he said a patient is presented with distended neck veins that increase on inspiration. This itself, guys, is a MCQ statement, that the person is having distended neck veins that increase on inspiration, because normally JVP is bound to fall on inspiration. I mean, the first line of the MCQ itself is sufficient for diagnosis, considering the fact that the patient is having a presence of a Kussmaul sign. So since I said there's a Kussmaul sign present in this patient, the differentials become limited to the mnemonic C or R that we have talked about. Let's read the question further. I mean, your thought process, whenever you read a question, JVP normally falls on inspiration. In case it rises, it's a Kussmaul sign, and that is when you are noticing that regular pulse is noticed, which is visible better than being felt on deep inspiration. Okay, so he's just trying to talk about a couple of other clinical findings, which I'll just mention. Some guys have mentioned that, but anyway, I'm giving opportunity to other guys to speak about what does he mean in the second line. There is no parasternal heave of a murmur. Parasternal heave basically talks about hypertrophy of the heart. You know, every time there's a valvular lesion, there is a hypertrophy in a patient, and then there's a third heart sound which is present. Okay, so I think a couple of guys did commented there that there is a pulse, but the pulse is regular pulse is noticed, which is visible better than being felt. What that basically means is the doctor is not able to actually feel the pulse properly, especially during inspiration, and the pulse that tends to disappear on inspiration is called as pulsus paradoxus. So I think one doctor or two, three doctors, in fact, in the chat would be doctors, have commented very correctly with respect to presence of pulsus paradoxus in the second line. And if you combine these two facts together, then it's not cardiac tamponade, because you do not get cardiac, because small sign is not seen in cardiac tamponade. Small sign is a feature which is seen in constrictive pericarditis. The correct answer for this one is option number C. And anyway, tricuspid stenosis can be ruled out because there is a murmur present in this case, because tricuspid stenosis ka jo murmur hota hai, that would be a mid diastolic murmur. He himself said that on auscultation there is no murmur present. Aortic regurgitation, if it's gonna be on long-term basis, it can cause a hypertrophy of the heart. So there's no heave present in this patient. Plus, more importantly, aortic regurgitation, if it is mild, then it should cause a early diastolic murmur. If it is severe, it should cause a mid diastolic murmur. So I'm ruling out A versus B in this patient primarily because there is no murmur which is heard. We are left between C versus D, and D again is very unlikely because there's no smoking given in a question. Considering that there is no mention of any smoking, I can easily rule out option number D in the question as well. The correct one is option number C. Yep, we get Bacterial with cardiac tamponade, but is not present in this case. So you can rule that out. And anyway, I mean, I'll just dedicate a slide to this diseases of the outside of the heart. They love to ask about it. So every time you are getting a question with respect to constrictive pericarditis versus cardiac tamponade, I expect you to be able to differentiate the two on the basis of a couple of parameters which are going to be very classically given in the exam. One of the important parameters that would be given, I mean, Bacterial is a piece of cake. Bacterial is a piece of cake that everybody is able to answer. So you will notice that he is going to talk about pulsus paradoxus, which is not a part of the Bacterial, and pulsus paradoxus is encountered in both of them. The differentiating feature will be that in case you get a question on pulsus paradoxus in which small sign is present versus small sign is not present, that would give you an important hint. And if you're still struggling in the exam, then another way to solve it is the ECG finding. Because constrictive pericarditis, there would be a low voltage ECG. The reason for that being that there is a calcification outside the heart. In cardiac tamponade, on the other hand, there would not be a low voltage ECG, but rather there would be a electrical alternance present in the patient. Most of the time the differentiation can be made on basis of this. Otherwise, he might even give you an echocardiographic finding of a diastolic collapse of ventricles. I mean, every time you read about diastolic collapse of the ventricles, that's gonna be cardiac tamponade. Intrapericardial pressure is gonna exceed that. So I mean, and in this particular case, I mean, the echocardiography can show evidence of calcification, though calcification can be picked up even better on a cardiac MRI or maybe on a CT scan. But then there are a couple of points which would always be given in a question that can help you differentiate between the two. But since in the previous years, JVP findings are to be focused, and then diseases of the outside of the heart, especially these two, constrictive pericarditis and cardiac tamponade, are to be solved. I mean, Bacterial, I have not spoken about because that's pretty easy. All of you know about those muffled heart sounds and elevated JVP, the non-pulsatile elevated JVP, those are, and hypertension, and those are pretty standard and easy ones. So, I mean, these are the core issues which you should be able to work out. And yep, I think Dr. Abhi helped me with another one that I should have said. Yep, thank you, Abhi, for reminding me to say this. Both MCQs will be talking about a steep X, but then there's gonna be a fundamental difference that in constrictive pericarditis there's gonna be a steep Y, whereas when it comes to a cardiac tamponade, it's gonna be absent Y descent. So cool, Abhi. I mean, you did make a very pertinent point and at the right time, so that I do not miss out in saying that. So I think if you get this table right, isko mind mein imprint kar lena yaar. Iska not a single line of this that I am saying should be missed out by you. And I'm not doing any routine chit chat. I'm trying to focus on those core topics which are being asked in the exam. And if you just get these facts right, I'm very sure you're gonna be able to score as beautifully as you are doing right now. I mean, PYQs में 100% strike rate चाहिए. The opening line में The first two questions, some guys messed up in some initial questions. That always happens. When you go for any exam, right from the first minute to the last minute, the same amount of mental stamina should be maintained. The same amount of mental aggression should be maintained. It's not that first 2-3 balls you're missing and then you are planning to go and hit a six. I mean, that should not be the strategy. It should be like hitting the ball out of the park right from the first ball itself. Okay, thank you so much. Let's move on. The next question. A young patient develops bout of acute dysentery and he develops a bilateral ascending quadriplegia. I mean, the question is like shouting, pick me up, diagnose me. Bilateral ascending symmetrical paralysis. Whenever he says bilateral ascending quadriplegia developing in a patient, the question is like screaming that, okay, I post acute dysentery, that, okay, I am Guillain-Barré syndrome. The correct answer for this one, very good, is option number A. Tell me the name of the diagnostic criteria that are used for diagnosis of GBS. There are multiple organisms which could be responsible for it. Campylobacter jejuni is one of the important ones. But anyway, for this particular case, because it was dysentery, but then we have had instances of Guillain-Barré syndrome, post-Zika virus, post-Epstein-Barr virus, post-SARS-CoV-2. Those are a couple of etiological factors which have been responsible, demonstrated to contribute to this. Yes, can I have the name of the diagnostic criteria, guys? In this case, it was probably Campylobacter jejuni because there's a dysentery given. But yep, I'm still waiting for you guys to comment on the name of the diagnostic criteria. We'll talk about immunoglobulins. Exactly. Medico was the first one to come up with it. That is gonna be Brighton criteria are useful for diagnosis of this condition. In Brighton criteria, we'll be doing the following aspects. Let's do a quick practice. You should be having a presence of ascending. Yes, you should be having a presence of ascending symmetrical paralysis. And along with this ascending symmetrical paralysis, there should be reflexes that should either be absent or the reflexes in the patient should be substantially reduced. So the clinical domain is ascending symmetrical paralysis with a hyporeflexia or a areflexia. The additional points would be albuminocytological dissociation. When you do the lumbar puncture of these patients, everything is going to be normal except the proteins because this is an autoimmune condition. So as Abhi mentioned, there's going to be a elevated protein with a normal CSF count. And the third important feature would be electrodiagnostic test. That's going to be nerve conduction velocity. And nerve conduction velocity is going to show a slow conduction, or he's just going to use words like increased distal latency, or he's going to say that the F wave of the patient is showing an increased latency. That increased latency of the F wave is again because of the demyelination which is occurring in this case. And then we'll use immunoglobulins for this patient. Some guys started commenting for transverse myelitis also. Good. I really like that, doctor, that you commented for transverse myelitis. How can you rule it out? Transverse myelitis will always be having a sensory involvement. And because in this question it is given that pain and proprioception sensation is preserved. So that goes against the diagnosis. Though, I mean, we can have variants of Guillain-Barré syndrome where sensory involvement can be seen. But usually if it is AMAN or AIDP, the major symptoms are going to be motor only. So considering sensory involvement is not given here, transverse myelitis looks a little unlikely. And then more importantly, when it comes to transverse myelitis in a patient, that classical, I mean, the bilateral involvement that is seen in the patient, that may not be present at all the times. And more importantly, transverse myelitis will start having a bladder involvement, bowel involvement, which is not given in this case. So in case you read about urinary incontinence, you read about fecal incontinence, then yep, transverse myelitis is to be considered. And the test to be done for transverse myelitis would be MRI of the spine that will show inflammation, and we'll be giving steroids in this case. So for option number A, which is the answer to this question, we give immunoglobulin / plasmapheresis. Or depending on the situation, most of the time it's immunoglobulin first and then plasmapheresis, or a combination can also be tried out. But in transverse myelitis, we'll be mainly using steroids in the patient. Then polymyositis mainly will present with muscle weakness, but it will not have a classical term like bilateral ascending paralysis present. And myasthenia gravis, the point against myasthenia gravis would be that myasthenia will always be having that classical diurnal variation that should be present in the question, because if you read about a ptosis, that's not there in the morning, but is present in the evening hours, is present in the afternoon hours. That is where you have to think in terms of, Myasthenia gravis will present with diplopia and ptosis. A lot of patients may not be able to appreciate the ptosis. They may just say that, my friends call me a sleepyhead, कि यार तू तो सोता रहता है. If you're having a ptosis, if person is having a bilateral asymmetrical ptosis because the eyes are partially shut, his friends, he may not say that I have a ptosis. They don't know the technical word. Patient might say that, my friends call me a sleepyhead, though I don't feel like sleeping. But because of the ptosis component, his visual field will also be restricted, and more importantly, there would be double vision present because there's an asymmetrical ptosis. So the question of myasthenia gravis will also be discussed subsequently, but yep, that's one of the very important topics that is always asked. So whenever you're going through CNS topic, one, CNS infections, meningitis, encephalitis component, etiology, then you need to read about GBS versus transverse myelitis, and then in peripheral nervous system, myasthenia gravis. Those are like must know topics for your FMG exam. No, Dr. Gautam, no. Myasthenia gravis has a peculiarity. In fact, good that you asked it, because this is again a question from the previous exam, one-liner question saying motor weakness with preserved deep tendon reflexes is a feature of. Motor weakness with preserved deep tendon reflexes is a feature of, then your answer is going to be myasthenia gravis. So we'll not have a reflex here, Dr. Raj, there. We'll be having normal reflexes in patients of myasthenia gravis. So cool. We sorted with question number 9. Let's move on to the 11th one. What is the commonest cause of death in diabetic ketoacidosis? I know that somewhere answer is given as dehydration also. My reference is OP-Ghai, the text, because the question is regarding diabetic ketoacidosis, especially with respect to a kid. So, okay, Lambert-Eaton doc will cater to that when I discuss the myasthenia gravis question. The leading cause of death in a diabetic ketoacidosis should be first given as cerebral edema. The reference for this is OP-Ghai. Even the latest edition of OP-Ghai says this line. You can check it out. The new red edition that has come, that also mentions the leading cause of mortality in diabetic ketoacidosis happens to be cerebral edema. Okay, so cool. And in diabetic ketoacidosis, then he can ask you regarding the investigation of choice. He can ask you regarding the first line management, and he can ask you the treatment of choice for these patients. So quick answers here. First is the IOC for this condition, guys. How do you confirm this is diabetic ketoacidosis? What would you do? In adults, it is ARDS. Okay, fine. Cerebral edema is because of multiple reasons. One of the reasons for cerebral edema would be that there would be protons present. Protons will cause damage to the blood-brain barrier, and this damage to blood-brain barrier will cause cerebral edema in a patient. That is one explanation, acidosis. Another reason for this can be because there's a high sugar, so there is fluid shifts across the brain. Anytime blood sugar of the patient is grossly elevated, 400 mg%, then there can be fluid shifts across the brain. And along with this, I can say that electrolyte imbalances that occur along with high sugar can also explain the fluid shifts and can contribute to this. Okay, I heard a ABG. The first test that you will be doing to confirm the diagnosis would be you are right, we do I think I've explained this, guys, that dipstick for ketones may not be very accurate, because the dipstick may not be able to pick up the most acidic ketone body. Yeah, we use a dipstick, I agree to that, but the point is that the dipstick may not be able to pick up the most acidic ketone body, that is beta hydroxybutyrate. So for confirmation of diagnosis, I think I've said that in the main video, we go in for plasma beta hydroxybutyrate levels. And yeah, आपने जो dipstick बोला, that is okay. It's not that your answer is wrong. I'm just trying to refine what you were saying, that if I am gonna try and use a dipstick, sometimes I might be having false negative reports also. So plasma beta hydroxybutyrate levels would confirm that I'm dealing with diabetic ketoacidosis. I'll have to give normal saline to this patient, and the treatment for this, sir, you can switch off, close your YouTube and start again, and your screen will be clear. And the treatment of choice for these patients, the subsequent treatment would be to start the patient on an insulin drip, because lots of time if your internet speed is slow, the YouTube will decrease the resolution of the video. So yep, it is insulin drip, and we have to give regular insulin to this patient, and any dehydration that is present is primarily to be corrected. And then also hold insulin. That's another point that has been asked in an FMG exam, that you have to hold insulin in case the potassium values on admission are less than 3.3 milliculents. That is primarily because insulin will be causing potassium to go inside the cells. Insulin causes potassium to go inside the cells. So hold insulin in the patient in case the potassium is less than 3.3. The logic behind that is pretty straightforward, that insulin causes potassium to go inside the cells. So in case person is already having a low potassium, you start insulin trap, dangerous hypokalemia can be triggered in a patient. Therefore, anytime if diabetic ketoacidosis patient presents with vomiting, because lots of time diabetic ketoacidosis patients will present with vomiting. The reason for that is ketonemia. The ketones will cause stimulation of the vomiting center, that's the chemoreceptor trigger zone, and that will trigger vomiting, and vomiting then will result in hypokalemia in a patient. And once there is a hypokalemia, the logic, I'll repeat that again. I said ketonemia causes the vomiting center to be stimulated, and that causes severe hypokalemia on presentation. And because of that, if case you start insulin trap, the potassium can decrease subsequently. Raj says they die from sepsis. No, doc, you are there to prevent that sepsis and give antibiotics in case that is required. I mean, your logic is fine that if the sugar is elevated, there is a higher incidence of infections. But unless and until diabetic ketoacidosis is triggered by sepsis, unless and until diabetic ketoacidosis is triggered by sepsis, tab tak hum will not have mortality due to septic shock. The usual reason is cerebral edema in a patient. Okay, Dr. Yadav, I'll try to be a little slow in a patient. Abhi, you're right. I mean, vomiting will cause hypochloremia also, but the main concept is कि अगर पेशेंट को वॉमिटिंग होता है तो उसका पोटेशियम पहले से ही कम होता है ना यार. तो अगर पोटेशियम पहले से ही कम है, आप इंसुलिन दे दोगे तो और कम हो जाएगा. तो हम नहीं चाहते ऐसे. तो हम पहले पोटेशियम की वैल्यू चेक करते हैं, और अगर जरूरत पड़े, if the need arises, we will add potassium chloride. This is if needed. We'll add potassium chloride if needed to the bottle of normal saline, correct the potassium values, and then resume insulin drip for this patient. Metabolic alkalosis, okay, fine. आपने शायद you mainly pointed that vomiting will cause alkalosis. That's okay, but the point is this guy is having excess ketones in his body at the moment. Nikki, small breathing is one of the acidotic hyperventilation that would be encountered in these patients, which is a method of compensation. Okay, so we sorted for 11, and yeah, Pankaj, we are doing all repeat questions today. Today's session is PYQs. If you check the distribution of the video, no, our objective is to practice all the PYQs so that we are going to have 100% strike rate. Okay, so that's the reason why we are doing older questions today and not newer ones. It's all PYQs. I want you to get 100% strike rate in the same. Drug which decreases mortality in congestive heart failure. So anytime we are dealing with the CHF patient, beta blockers would be the main approach that you are using. 2 MCQs in cardiology where beta blockers are gonna show mortality. Both begin with alphabet C. That is gonna be chronic stable angina, and second is gonna be chronic congestive heart failure. And now I'm asking the opposite question. Tell me what drug in congestive heart failure has not been shown to reduce mortality. We give for acute congestive heart failure LMNOP, that is Lasix, morphine, nitrates, oxygen. Positioning of the patient, you can take like light Lasix, morphine, nitrates as options, and you want more options, you can add ACE inhibitor. But the question was not reduce mortality in congestive heart failure. Absolutely, J has been spot on in that answer. Which has not been able to show reduction in mortality is nitrates. Nitrates are mainly for in congestive heart failure. Nitrates are mainly for, I can put it like this, they're mainly for symptomatic relief, but they do not show mortality reduction. In fact, first I would like to highlight it for chronic stable angina, CSA. In fact, that's a more appropriate statement, and then even for congestive heart failure as well. Digoxin is nowadays not used for management of congestive heart failure anyway. So not reduce mortality in chronic stable angina / CHF is nitrates, and then even calcium channel blockers, because calcium channel blockers cause a reflex tachycardia, so heart ki oxygen consumption बढ़ जाती है. So they've not been able to show reduction in mortality. Nitrates are used in MI, doctor, that's okay. You know, we use nitrates for myocardial infarction, but we do not use nitrates in couple of scenarios. Like nitrates are contraindicated in case it's an inferior wall MI. Nitrates are contraindicated if the systolic blood pressure is less than 80 millimeter of mercury. So they are for symptomatic relief, that is okay, but then nitrates are used in MI but are not used in inferior MI. Okay, ji. Fine. So a couple of aspects here from cardiology that I have mentioned, especially for heart failure with reduced ejection fraction. We are going to use LMNOP, that is Lasix, morphine, nitrates, oxygen positioning for the patient initially, and then once he goes into chronic congestive heart failure, ACE inhibitor and beta blockers would be used. 12 is sorted. We come to 13. He says, talk about the components of the Child-Pugh score in a patient. The components are already on the slide. I'm just making you practice this once again because anytime the liver is damaged, bilirubin is anyway a component, right? Thrombolytics are contraindicated and unstable angina. Okay, doctor, I think I've said that in rapid revision, but I'll try to do that quickly, mainly because you put up that question. So let me just write down the components here: bilirubin, albumin. Albumin is low, so ascites would be resulting in a patient. Along with that, if the liver is damaged, therefore ammonia will rise, so asterixis. So it's a encephalopathy. There is a ascites component, albumin, bilirubin, and prothrombin time. Hepatitis is not a component, so you have to select between A versus B only. The correct one is option number A. One doctor said, why we don't use it in unstable angina? Doctor, in unstable angina, the clot is already broken down. If the clot is already broken down, if you will do thrombolysis, it will break the clot into further small pieces and will cause worsening of a patient. Unstable angina is one step below MI. It's one step below non-ST elevation MI. Usme already the clot is broken down. So if the clot is already broken down into pieces and you try to break it into further smaller pieces, it's gonna cause it's gonna cause atherombolism. In fact, the key word somebody did point there. Yes, Dr. Bindas Chacha. Yeah, a good name. So Dr. Bindas has helped me there. You know, there's a atherombolism. The clots are already broken, and if you break them into further pieces, then there would be deterioration of the patients. Child-Pugh score and MELD score are both used for determining the severity of stenosis as well as to cirrhosis and need for orthoptic liver transplantation. Those are the two situations where okay, so those are the two situations in which there would be a need for orthoptic liver transplantation in a patient. Okay, guys, so you can comment in the chat box with respect to whether everything is fine. Things are bound to go wrong when you least expect it. Okay, I will repeat the fact. I think there was some transitional issue, but anything, so far so good. I'll repeat the fact once again, guys. The point is, why do you calculate a Child-Pugh score? Why do you calculate a MELD score? The reason behind calculating the MELD score or the reason for calculating the Child-Pugh score is to decide the need for ऑर्थोप्टिक लिवर ट्रांसप्लांटेशन. जैसे अगर मुझे रजिस्टर करना है अ पेशेंट फॉर ऑर्थोप्टिक लिवर ट्रांसप्लांटेशन इफ द MELD स्कोर इज मोर देन 17, we register them on a UNOS, United Network for Organ Sharing website, so that once we have a liver available, then liver transplantation in the patient can be done. So पहले तो I mean there are two reasons which I've said. One is to determine how bad the cirrhosis is, compensated, decompensated, that's one. And second, because a person is progressing from compensated to decompensated, though the best way to save his life is to go ahead with liver transplantation. So to decide for these, we go in for values like in case Child-Pugh score values go in excess of 8, that is need for liver transplantation, or MELD score values more than 17. I mean, I don't expect that he is gonna ask you these values, but that is just to sensitize you to the fact that I want to know the progression of the disease. And once the child values go more than 8 or MELD values go more than 17, that's when we register these patients on UNSOS website and then plan a liver transplantation. Okay, let's move on to the 14th one for today. Fairly a longish and a nasty question, so I decided to keep this in our today's discussion. The question was regarding a 70-year-old smoker who was presented with high-grade fever, cough and contusion with diarrhea. So, I mean, a combination of cough and diarrhea is a little unusual, but then it's okay. And then he says that there is bilateral infiltrates in both the lower lung fields of the patient. He's not given an X-ray, but he's saying that the bilateral infiltrates both lung fields. On the sputum gram stain, no organisms were detected. The sodium of the patient is on the lower side, and 126, normal is 135 to 145. AST, ALT are slightly elevated. They should be less than 45, each one of them. They're also elevated. Then random blood sugar of the patient is 112. Any sick patient, blood sugar can be slightly elevated. Serum bilirubin is normal. He's trying to confuse us with so much of data. So we need to find out what is going on. The first and the foremost thing is, because in the MCQ is saying bilateral infiltrates in both the lung fields. So my presumptive diagnosis based on a guy who's having fever, cough and X-ray finding is that he's having a pneumonia. Now I'm thinking to myself, is it a typical pneumonia or is it a atypical pneumonia? Because if it is a typical pneumonia like caused by Streptococcus bacteria, as somebody answered, then Streptococcus pneumonia should be contributing to a lobar pneumonia. I mean, the radiological finding for Streptococcus should be something like this, that there should be infiltration in one lobe of the lung, like that's a lobar pneumonia. But he has himself mentioned bilateral infiltrates in both the lung fields of the patient. So it is not a typical pneumonia, and this is not Streptococcus. This is not Klebsiella, because option number A and D, they both result in a lobar pneumonia in a patient. Anyway, for Klebsiella, he usually tends to give a hint for the color of the sputum, also a red currant jelly sputum. So I am left between B versus C. For C, pneumocystis jirovecii, usually the scenario given will be for a HIV positive patient. So you have to solve this question by exclusion. I'll do the exclusion part once again, because I made a diagnosis of pneumonia on the basis of fever, cough and bilateral infiltrates. I have to think it typical hoga ya atypical hoga. Typical pneumonia, Streptococcus, and then is Klebsiella. Both of them will cause, at least both of them will cause a lobar infiltration. Here it is bilateral infiltration given. So that is why A and D were ruled out. And for B versus C, C should be having a supportive evidence of HIV positive patient. So by exclusion, the correct answer for this question is option number B. And in case you find this hard to remember, then you have to use an alternative method to solve it, what Vinod has said. And that is electrolyte imbalance in a case of pneumonia. Every time you read about electrolyte imbalance in a case of pneumonia, hyponatremia in a pneumonia patient, it tells you that the bacteria responsible is Legionella. Because Legionella karta kya hai? Legionella causes development of SIADH, that is syndrome of inappropriate ADH secretion. As antidiuretic hormone levels will rise, the rise of ADH will cause more water in the body, and the more water in the body will then contribute to a dilution, and because of that the sodium values in the body will tend to reduce. So the bottom line is कि भाई either तो आप ये याद करो कि Legionella causes dilutional hyponatremia, it causes a euvolemic hyponatremia. Or agar if you find that hard to remember, then you need to go in with exclusion capability, which is typical versus atypical. So whichever you find comfortable, but the point is the questions have to be spot on for solving this. And Parth, not exactly. In most patients of the pneumocystis jirovecii, X-ray will be normal. In most patients of jirovecii, X-ray will be normal or will be having bilateral infiltrates. But to say ground glass is technically not a very right statement, I would say, because ground glass is what you usually see either with silicosis or with asbestosis or with interstitial lung disease or with COVID-19 pneumonia. So, I mean, just a slight modification of what you have said. Otherwise, in majority of cases, X-ray is either going to be normal or will show bilateral infiltrates, bilateral patchy infiltrates in both the all the lobes of both left and the right side. So we are sorted for this one, guys. I think SIADH is the main key for this question. Every time you get a question, जिसमें cough, pneumonia or फिर diarrhea भी दिया हुआ है, that is again a point towards a presence of a atypical pneumonia in a patient. So we sorted with 14, that is beta. Let's move on to the 15th one. Which of the following is a cause of exudative pleural effusion? When I say exudative, it means there is inflammation present. And you need to pick up the inflammatory cause here. I think I have solved the question for you by just saying this word. Exudative is inflammation. It's the light criteria which are to be used in this case. You need to practice those lights criteria. Pleural fluid protein values and LDH values are the ones which are to be picked up. Since I've said inflammation, I think everybody was able to spot on, get this question right. The correct answer for this would be D, that is rheumatoid arthritis. We have rheumatoid nodules present here. That's an inflammatory condition. So that's why you would have exudative pleural effusion. For the remaining conditions, cardiac failure, there's going to be a hydrostatic pressure change. Liver cirrhosis, albumin will become less. Nephrotic syndrome also, albumin will become less. So the oncotic pressure will reduce. I mean, the concept behind why B and C is not the answer is both will cause low albumin, and low albumin is then gonna contribute to generation of decrease in the oncotic pressure. Oncotic pressure becoming lesser, that is transudative. Or for cardiac failure, there's gonna be an increase in the hydrostatic pressure. In case of the data that is mentioned on the slide here, hydrostatic versus oncotic, that's always gonna be transudative. The correct answer for this one would be option number D. Yep. Hitesh, I could not get your point, but yes, it's mainly the Lights criteria which will help in diagnosis. For exudate, the values will always be more than. The values would be like protein more than the 0.5 times the value of the serum protein, pleural fluid LDH more than 0.6, or pleural fluid LDH more than 2/3 the upper reference limit. I mean, I've not written the data for the protein and the LDH, but these are the mathematical values. More, they go in favor of an exudate. And if they're gonna be less, then they're gonna go in favor of a transudate. So great guys, answer to 15 is delta. I got a C there also. वो मैंने समझाई कि नेफ्रोटिक से एल्ब्यूमिन कम हो जाएगा, that will cause a oncotic pressure to be lesser. जब भी हाइड्रोस्टैटिक प्रेशर में चेंज होता है या oncotic प्रेशर में चेंज होता है, either of the two pressures changing, it's always gonna be transudative. Option number A, B, C, they're all examples of transudative variety of pleural effusion. Okay, so let's move on to the 16th question. A child has developed recurrent lung infections with a thickened sputum, and chest X-ray shows a bronchial wall thickening. Any kid with recurrent lung infections, there can be multiple reasons for that. One of the important reasons for recurrent pneumonia in children is congenital heart disease. But if it is not congenital heart disease, then there could be a possibility of diseases like cystic fibrosis, or there can be myopathies or muscular dystrophies due to which recurrent pneumonia can occur. I mean, every time you read about recurrent pneumonia in a child, what is your thought process? Your thought process should be, the question can be related to left to right sided shunts like AST, VST, PDA. That's where recurrent pneumonias can be seen. Then children with Down syndrome tend to have hypotonia. Because of hypotonia, the strength of the muscles is lesser. Therefore, the kid could be having recurrent pneumonia. Then any kid with muscular dystrophy, any kid with myopathy, he could be having recurrent pneumonias. And then another one to be considered is cystic fibrosis, where the lung secretions are going to be thick. So that's your thought process every time you read about recurrent pneumonia. The question says that he has also been suffering from steatorrhea since birth. So what you need to link up here is that a person is having a lung involvement as well as a GI involvement, and the GI involvement is present since birth. So there has to be some congenital problem in this case. Now, when you look at option number A, cystic fibrosis can cause malabsorption syndrome, especially because the pancreatic secretions would be very, very thick. So because the pancreatic juice will be very thick, it will not be able to come out. If pancreatic juice is not able to come out, the concentration of pancreatic amylase in the gut will be lesser, and therefore sugar will not be absorbed, and therefore there can be osmotic diarrhea. Pancreatic lipase will also be hampered. So if there's a lipase getting hampered, therefore there can be steatorrhea. So what I can say is that this looks like cystic fibrosis, but let's look at B, alpha-1 antitrypsin deficiency. Point against alpha-1 antitrypsin deficiency is it causes lung involvement, that is okay, but the second involvement is that of cirrhosis, and there is no liver involvement given in this question. So I'm ruling out option number B. Hyaline membrane disease is anyway ruled out because it will be a presentation of a preterm baby with respiratory distress. So you are left between A versus D. And between that, malabsorption syndrome will then only have GI complaints. Malabsorption syndrome will not have any lung complaints in a patient. What you have to think in this question is that there is a combination of lung involvement as well as a GI involvement in a patient. Malabsorption syndrome will cause only a GI involvement. Hyaline membrane disease will cause only lung involvement. Alpha-1 antitrypsin deficiency will cause combination of bronchiectasis, will cause emphysema, pan-acinar emphysema with the development of cirrhosis, and it's cystic fibrosis which will cause bronchiectasis, and that's why the patient is having a bronchial wall thickening. I mean, since he says bronchial wall thickening, that means that there is purulent secretions plus there is inflammatory changes, so there's a bronchiectasis present in a patient. Alpha-1 antitrypsin causes Pannicular emphysema plus cirrhosis, and cystic fibrosis causes bronchuria plus lung involvement plus GI involvement of steatorrhea. The correct answer for this one is option number A. So, yep, I think you guys are maintaining a good strike rate till now. Alternative name for cystic fibrosis would be mucoviscidosis. This would be a defect related to chromosome number 7. It's autosomal recessive. There's a 508 mutation which is present here. So genetics is the in thing nowadays. So wherever possible, try to get the genes and the chromosomes right for each of these questions as well. I mean, the logic should be very clear, and causes of recurrent pneumonia, especially when it given a pediatric setup, should be known to you. The causes are left to right sided shunts. Downs is, I mean, hypotonia association, muscular dystrophy, again the same, and then cystic fibrosis. Blunting of villi in cystic fibrosis, no doctor, there would not be any villi getting blunted, but yeah, I mean, the pancreatic juice would be too thick and viscid. It's not going to come out, and therefore, due to the deficiency of pancreatic enzymes, we are going to be having a osmotic diarrhea, and we're going to have a steatorrhea in these patients. Yes, it's a deletion 508 mutation, F508 mutation, exactly. Okay, fine. Let's move on to the subsequent question. We have this man who presents with right hip pain and a back pain. At 70 years of age, if somebody comes to me with back pain and hip pain, I could be thinking in terms of possibly a disc prolapse, which could have compressed some nerve, and thereby the patient could have had this manifestation. I mean, my thought process initially is a prolapsed intervertebral disc. But then what he's saying is a little surprising, because he's saying the workup of the patient shows hemoglobin of 8, serum calcium of 12, serum creatinine is elevated, and bone marrow biopsy is showing plasma cells. So he is giving me those features of CRAB, that is hypercalcemia, and there's a renal failure. So creatinine is elevated, there's an anemia component, and he's also showing me a couple of lytic lesions. I mean, those lytic lesions can be visible mainly in the pelvis of the patient and in the hip of the patient. And I mean, since he is himself mentioning that patient is presented with pain, I don't need to actually try and focus on the X-ray findings, though I mean, CRAB features are given, so I know that I'm dealing with a patient with multiple myeloma. So in any old patient presenting to you with back pain, you need to think in terms of prolapsed intervertebral disc. You need to think in terms of cancer of the prostate. And the third, because prostate cancer goes to the lumbosacral spine, and that can cause low backache in a patient. And then after that, the next possibility which is to be considered is obviously multiple myeloma. 3 differentials for severe low back pain in an old man are disc prolapse, prostate cancer, and multiple myeloma. And considering that he has himself helped me with hypercalcemia, normal serum calcium is 9 to 11, it was given to be 12. Serum creatinine is 2.5, normally should be in the range of less than 1.5 depending on the age and weight of a person. Then is the anemia component, and then the bony lytic lesions, and are anyway gonna describe it. So yep. So we can make a diagnosis in this case as option number A, and you guys have to tell me the screening test for multiple myeloma. You have to tell me the investigational choice for multiple myeloma. You need to tell me the treatment algorithm for this condition. Quickly, guys, what would be the screening test for multiple myeloma? How would you confirm the diagnosis? First, let's look at the screening test in the patient. Okay, I got a fish as an answer for screening. Okay, so fish would tell me, I'm not asking for chronic myeloid leukemia, guys. We are not discussing chronic myeloid leukemia at the moment. I said screening for multiple myeloma. Okay, I'm still getting fish as an answer. So fish will only tell me about chromosomal abnormalities. There are so many chromosomal. Tell me the chromosomal abnormalities then for multiple myeloma. 13 can be abnormal, 17 can be abnormal. So, I mean, with fish, there's not a single chromosome that is defective. PET scan. Okay, so PET scan will tell me malignancy, or it will tell me lytic lesions, or will it give me a diagnosis of multiple myeloma? Come on, yes, Raj has come up with the first correct answer for this. We'll go for a screening test that would either be a urinary protein electrophoresis, or instead of going for a urinary protein electrophoresis, we can go in for a serum protein electrophoresis. I mean, for any condition that you read, guys, you have to be spot on for how do you diagnose that condition. I mean, you could have which are the places where we can see multiple myeloma like lesions. Multiple myeloma lesions are characteristic, doctor. They're raindrop configuration lesions. They're very classical. They would not be seen anywhere else. And anyway, in multiple myeloma, the classical lytic lesions are not starting from the skull. They start from the vertebra. They start from the lumbosacral spine and the pelvis and then move on to involve the skull. So absolutely, we need to go in for demonstrating the M spike present there. So either we can go in for a serum protein electrophoresis or a urinary electrophoresis. For confirmation, we'll go in for a bone marrow biopsy in which the cells should be more than 10%, plasma cells more than 10%, and the 60% cutoff is in case there is no CRAB features. I mean, plasma cells more than 10% would help in diagnosis in presence of CRAB. If the CRAB is absent, then the cutoff is taken up to be 60%. And for the treatment of this patient, we have to use multiple drugs. I think you guys have read them. I did not get very confirmatory or good answers, but lenalidomide, and then we use steroids in these patients also. So I mean, I expected multiple inputs here for the treatment of this condition, but any hematological condition, once you've read that from pathology, do read up about the screening and the investigation of choice and the treatment for the condition as well. Absolutely. Absolutely. And number one, as I said, the lytic lesions do not start from the skull. They start from the lumbosacral spine, which is the reason for the low back pain in the patient. As far as chronic myeloid leukemia is concerned, there your answer, yeah, bortezomib, that's another drug that we'll be using. Actually, I was waiting for somebody to say that. So I think one doctor did mention bortezomib. Okay, so yeah, Akib has made it easier for me in his comment. Thank you, Dr. Khan Akib. Bortezomib, lenalidomide, and dexamethasone. Those are the drugs that we'll be using for management of these patients. Due to lack of space, I'm just putting alphabet B there. Otherwise, it will become a scribble. So bortezomib absolutely on. And it's for the remaining conditions that you will be going in for, for chronic myeloid leukemia, you'll go in for a FISH or a PCR, by which you can make a diagnosis. And in acute myeloid leukemia, you'll be doing a flow cytometry on the bone marrow specimen. You'll be doing a bone marrow aspiration, and that would help you. And the same is the case with ALL also. You can do a flow cytometry on the bone marrow aspiration, and you can differentiate because the cells would be having different numbers there. The treatment part, yes, you can revise them from pharmacology, imatinib. Then for AML, cetarabine is one of the drugs that would be used. Though most of the time he'll ask you about M3 variety where Atra is used. So, high live. Chalo, answer to 17 is option number A. A lot of data on this slide. Every time you get a question on low back pain in an old man, think in terms of disc prolapse, then think in terms of prostate cancer, and then think in terms of multiple myeloma in the patient. Okay, coming to 18, he says a 20-year-old patient oft repeated question. मतलब इतना cliche हो गया ना ये question कि I think people will read it and come up with answers. Person has had a URTI, and after URTI, periorbital edema is present in this patient. The periorbital edema is basically the kidneys getting involved. And he is himself telling you the kidney is involved because there are RBCs in the urine, there is protein present, BP is elevated. I mean, every time kidney is damaged, there's an elevation of blood pressure, and more importantly, the C3 levels are reduced. So C3 levels reduced, it can't be minimal chain disease, doctor. I mean, I did get, okay, I got C as an answer initially, doc. C3 levels are reduced. C3 levels are normal in minimal chain disease. You do not have RBCs in the urine. Guys, you can't make a mistake like that, right? RBCs in the urine are not present in minimal chain disease. This is a classical presentation of post-streptococcal glomerulonephritis. I mean, every time you get a question on a URTI, and after a URTI, after a couple of days, because we are going to be having immune complex mediated damage occurring here. The immune complex mediated damage will cause consumption of the complement system. So the complement C3 levels are reduced. I mean, the moment he says C3 being lesser, your thought process is this is glomerulonephritis. C3 lesser, glomerulonephritis in the patient. And then he's going to describe hematuria. And along with RBC, some amount of proteins will anyway come. The amount of protein in this case will be subnephrotic proteinuria. I mean, if RBCs are coming in the urine, then some amount of protein will also come. So he will obviously give some value of proteinuria. Like in this case, it is given to be only 800 milligram of protein plus gram of urinary creatinine. So I mean, with RBCs, some protein are anyway going to be present. And more importantly, this chap is having hypertension. Along with that, he's having expansion of his plasma volume because aldosterone values are elevated. So there is a edema occurring in this patient. So considering all the facts together here, our diagnosis would be PSGN. In case it was minimal chain disease, it would have been only a periorbital edema, but complement in the urine, complement levels would have been normal. I mean, why this is not the answer is C3 should be normal in this case. There should be no presence of hematuria in a patient. Minimal chain disease is very classical as a presentation, and you do not have hypertension. Anti-DNS-A antibody present here. Doctor, that antibody is present because of the infection, no? That antibody that is present here is not to be mixed up with double-stranded DNA antibody of SLE. This anti-DNA-A antibody is against the Streptococcus bacteria. This is because this person was having infection with group A, beta hemolytic Streptococcus. नहीं सर, वो ऐसा नहीं है कि बच्चे में ही होगा. I mean, you can be having minimal chain disease presenting in adults also. That's not the case. So yeah, I mean, your point is right that age will help in confirmation of diagnosis. That's okay. And one doctor asks why the antibody is there. The antibody is because of the bacterial infection. So it's a immune complex manifestation. And yeah, I mean, for minimal chain disease, the pediatric concept is okay that बच्चे में होना चाहिए, but can be present in adults also. So you need to take into consideration other parameters also. C3 being normal and absence of hematuria is what will make you think in terms of minimal chain disease. For Goodpasture syndrome, you should be having two things: hemoptysis with hematuria, no hemoptysis given here, so I'm ruling it out. And anyway, A and C तो एक ही बात है ना यार. I mean, another reason why A and C is not the, I mean, unlikely to answer C, then because if you're answering C, then A should also be the answer, because nephrotic presents as minimal chain disease in pediatric age group. So I think the queries that were put up are sorted. Answer to 18 is delta. We move to the next one. A female has difficulty in standing up from a squatting position, cannot comb her hair. So the line, because difficulty in standing from squatting position, cannot comb hair. This is talking about proximal muscle weakness. It is deltoid muscle weakness and hip joint muscle weakness occurring here. Then there is a villaceous violet rash around the upper eyelid of the patient. That's a combination of skin manifestations. I mean, he has mentioned skin involvement plus he has talked about muscle involvement. So the combination of the two, the skin involvement and the muscle involvement, would be called as dermatomyositis. And yep, I think everybody got this one correct. Dermatomyositis will have a combination of proximal muscle weakness as well as a skin involvement, which would be in the form of this heliotrope rash, a violet rash around the upper eyelid of the patient. So cool. I think this was relatively a easier one. Yeah, Abhishek, Gawar sign actually classical is described only in Duchene's dystrophy. To say Gawar sign here would be a little slightly inappropriate. I mean, though we consider that very classical for Duchene's dystrophy only. Anti-Jovan antibody, doctor, is present only in case dermatomyositis is associated with interstitial lung disease. So don't answer that as the best way for diagnosis of this condition. Only if dermatomyositis is associated with interstitial lung disease, that anti-Jovan antibody can be present. Otherwise, it's not the antibody. It would be a MRI guided biopsy. It is MRI guided biopsy. Sir, in FMG solutions, there are about 500 to 600 MCQs. If you do them, you can, I mean, I think in 1.5 hours, we've already done 20, and here I'm doing 20 because I'm giving explanation also. So if you do them fast, I mean, there should be a 0% error. And anyway, yep. Anti-Jovan antibody, doctor, answer only if there's a dermatomyositis with the interstitial lung disease. Otherwise, it is a MRI guided biopsy for diagnosis of this patient. Yep. Let's move on subsequently. Moving to 20, HIV positive patient presents with cryptococcal meningitis. The main treatment for cryptococcal meningitis is liposomal amphotericin B. We actually give liposomal amphotericin B with flucytosine. The correct answer for this one is option number B. And please let me know the investigational choice for this condition, please. Yes, we sorted for the answer. That's not an issue. You have to answer me two questions. One is, what is the best way to confirm cryptococcal meningitis? Second, tell me condition. Which fungal infection? Do you answer voriconazole as the drug of choice? सीटी स्कैन से पता चल जाएगा कि क्रिप्टोकोकस है, ऑर्गेनिज्म पता चल जाएगा डॉक्टर साहब, नहीं पता चलेगा ना। कल्चर करेंगे, हाँ जी हाँ जी हाँ जी। तो क्या करेंगे सर, लंबर पंक्चर करके पहले सीएसएफ करेंगे। सीएसएफ पे क्या टेस्ट करेंगे सर? Yeah, you do a lumbar puncture, that's okay. He's asking the test on the CSF, and the answer is not gonna be India ink, right? India ink is not the best way, sir. India ink does not stain the organism, it stains the background. No, it stains the background. No, sir. India ink is not the best way for diagnosis. It is CSF ELISA for cryptococcal antigen. We call it CRAG, CRAG. It is CSF ELISA for cryptococcal antigen, which is useful for diagnosis of this condition. Patient is refused lumbar puncture. अब बताओ क्या करोगे? And is a question from the previous years. Any blood test that you have read about this condition? Yes, Dr. Manohar. Yes, you are right. But before we come to that, let's look at what these guys are saying. Suppose a patient is not gonna be ready for a lumbar puncture because the infection is gone via the blood. So what's the other test that has been done for this condition and has been asked in your exam? That's a lateral flow assay. Lateral flow assay has an advantage that it can be done even on the blood sample of this patient. For any infection that you're gonna read, make it a point. Uska main investigation should be clear to you. I mean, how do you identify this particular infection is present? So the correct answer for this is CSF ELISA for cryptococcal antigen is the best way for diagnosis. And on the blood test or blood sample, we can do a lateral flow assay. And voriconazole is the drug of choice for management of invasive aspergillosis. So we are sorted with the 20 pretty straightforward ones. Yes. VSH mentioned it right. Hi Niaz, good to see you. And moving to the next one, he says, which of the following tumor leads to hyperglycemia? Necrolytic migratory erythema with depression. And the main point is, I mean, he's talking about elevated blood sugar and he's talking about a skin manifestation. The skin manifestation has again been asked upteenth number of times in the exam. CD4 count would 100, okay, fine, agreed. I mean, though, I mean, we can get it at 150 also, 200 also. So that's not the prerequisite. Yes, the main point is, thank you, Farhan, for all the hearts, but they're turning out to be pink in color. Necrolytic migratory erythema would be with respect to glucagonoma. I mean, because insulinoma anyway will be causing a hypoglycemia. So I think he helped you in the exam with that by saying himself that the patient is having a hyperglycemia. VIPoma will cause a secretory diarrhea. It will cause a pancreatic cholera. The alternative name for VIPoma is called as pancreatic cholera. Please tell me which cells of the pancreas produce VIP. Yeah, there are D's present, dermatitis, diabetes mellitus, and depression present. That's a yeah, Niaz, you're right. Watery diarrhea with hypochlorhydria. Yep. Okay. सर एक ही कर लो, सारी कैसे करोगे? अगर एफएमजी सोल्यूशन से करना है आपको, तो अगर मैं टोटल कैलकुलेट करूं तो इट वुड बी लाइक 600 एमसीक्यूज इनटू 19 सब्जेक्ट्स, नो समथिंग लाइक दैट. सो आई थिंक द बुक वुड बी हैविंग मोर देन 5000 एमसीक्यूज. 6000 कर लो. So 6000 MCQs and how many can you do in a day? Maybe 100. So the number of days that you have starting from today till your exam, I mean 100 every day, plus you have to read notes also. So you have to be clear about what you are gonna do, right? So I would suggest you to do only one and just finish it cover to cover. At least try to do it 2 times. I think Dr. Jainil, that answers your query. 100 per day is the max possible, right? I mean, max you can pull someday 150 with explanation. I'm saying with explanation. So if you have to do that, then you have to. My suggestion is do any one and just get over with it. Chalo. Pancreatic cholera. Yeah, the question was which cells of the pancreas will produce VIP. I did not get answer, and it would be F cells. It's not delta cells. The D cells would be answer for this one. That would be somatostatin. That's the delta cells which are present. So I think guys messed up the question there. Best book for MCQ. सर बहुत सारी बुक्स हैं, आपको जो अच्छी लगे आप वो कर लीजिए. वीआईपीओमा वेजो एक्टिव इंटेस्टिनल पॉलीपेप्टाइड कहाँ से प्रोड्यूस होता है? मैंने सवाल पूछा था, मुझे एक बंदे ने आंसर दिया सिर्फ. It is VIP cells are produced by F cells. Islet cells तो सर इंसुलिनोमा वाले होते हैं ना सर. पैंक्रियाज में अल्फा सेल होते हैं, बीटा सेल होते हैं, डेल्टा सेल होते हैं, एफ सेल होते हैं, जी सेल होते हैं, जी सेल्स होते हैं. तो अल्फा सेल्स का ट्यूमर होगा तो ग्लूकेगोनोमा हो जाएगा. बीटा cells would be insulinoma, in which you read about Whipple's triad, and 72-hour prolonged fasting test. Then would be somatostatinoma. The F cells would be VIP oma, and then G cells would be a gastrinoma, that is Zollinger-Ellison syndrome. So these are a couple of cells tumors that you should be aware of. And anyway, since he's mentioning hyperglycemia, the question becomes easy: glucagonoma, along with the classical skin lesion, necrolytic migratory erythema. Moving to the next one, secretory diarrhea with hypokalemia and hypovolemia seen with which pancreatic tumor. So they love to ask for pancreatic tumors. In case you've not read them, go to the endocrine section, the very first video, just go through that, invest half an hour into pancreatic tumors. I know you read about pancreatic neuroendocrine tumors from surgery also, but my suggestion would be that in case you go through the endocrine section, read about insulinoma, glucagonoma, VIPomas from the medicine part also, and you will be in a better position to solve those questions. Yes, the correct answer for this would be a VIPoma. So secretory diarrhea with hypokalemia and hypovolemia is common in pancreatic tumor. Vasoactive intestinal polypeptide. Yes, doctor, we are coming for that. If he says what is the investigational choice for insulinoma, then for insulinoma we need to go in for RIA tests. That is, RIA would be that we'll be checking out the fasting insulin levels. Plus, apart from that, we will be checking out blood sugar values in the patient also. We'll be checking out C peptide levels, and we'll be checking out the blood sugar of the patient. In fact, when we're going to do this test, since you asked the name of the test, I was just taking a lag period so that people can answer this and help me with this. We are going to test three things: insulin, C-peptide, and blood sugar. The logic is that normally when blood sugar falls, then insulin and C-peptide level should also fall. But in this condition, what will happen is that in spite of the blood sugar being ultra low, though the blood sugar of the patient will turn out to be ultra low, the values of C-peptide and insulin will be grossly elevated. The test that you asked me is called as 72-hour prolonged fasting test. In 72-hour prolonged fasting, we are gonna be taking multiple blood sample of the patient at various intervals. Once he starts having hypoglycemia related symptoms and the blood sugar of the patient is on the lower side, when you check out the insulin C-peptide, you expected the values to decrease. Insulin production stops when blood sugar is less than 70. But यहाँ पे, because it's a tumor, the tumor will continue to produce excess amount of these two hormones. So 72-hour prolonged fasting test is the investigation choice for insulinoma. Right, so that is one aspect. Second is कि इसका imaging कैसे करते हैं. So the imaging for this condition, we have multiple strategies available. For imaging, we can be going in for a PET, we can be going in for a CT or MRI, or we can be going in for endoscopic ultrasound also. So these are, and somatostatin receptor studies. So I'll resolve that issue of what is the best imaging strategy used for these patients, but these are a couple of them that are currently available for evaluation of a insulinoma, a PET, a CT, MRI, endoscopic ultrasound, and a somatostatin based studies. There is a question subsequently, what is the best test for diagnosis of a pancreatic neuroendocrine tumor? So there I'll handle up the imaging part. But since the query was asked, how do you diagnose a insulinoma? I think I have answered Dr. Iqbal for the same. And the correct answer for this question is option number C. Yeah, the question just popped up. What is the best test for diagnosis of a pancreatic neuroendocrine tumor? He's not specifying an insulinoma. He's just specifying per se for pancreatic neuroendocrine tumors, what would be the test that is available. Now, endoscopic ultrasound, yes, we do that. Absolutely, we go in for this. The point is, in most of the books, when it comes to diagnosis of this condition, pancreatic neuroendocrine tumors, there are two ways for diagnosis. One is a PET CT, and second is going ahead with an MRI in a patient. I know that lot of people will give different answers. Actually, Harrison is mentioning only with respect to MRI. Yep. Harrison is mentioning only with respect to an MRI, Then we have a scintigraphy also available. We have a PET CT also available. The question will say which is overall the best test for diagnosis. The limitation of a MRI or a CT scan is only that if the tumor is smaller. In fact, he says first investigation to be done is always a CT or a MRI. Anytime you have a tumor, you have to do a CT or a MRI. The only limitation of this CT or MRI is that if the size of the tumor is less than 1 centimeter, then a CT or MRI will not be able to visualize it, and that is when we'll have to go in for a PET CT in a patient. So if he says overall what is the best test for diagnosis of this condition, we not a CT enteroscopy, sir. CT enteroscopy is what you do for, some people are answering C. CT enteroscopy is for inflammatory bowel disease. In case we were talking about Crohn's, we are talking about ulcerative colitis. That is when we can do for a CT enteroscopy in a patient. He says the first investigation to be done in the patient is always an MRI. But then overall the best, yeah, okay, I'll take rest. I had a live class actually in Bhubaneswar, and it was back-to-back long hours. Thank you so much. Then we'll go in for a PET CT in a patient. So thank you, Shubham, for the kind words. First is MRI, then is a PET CT, the overall the best one. Option number C is for Crohn's and ulcerative colitis. Moving to 24, a post-menopausal woman has presented with knee pain. Joint aspiration was done and shows negatively birefringent crystals in a polarized microscopy. Very classical. The only point was that it was knee pain and it was not a toe pain in a patient. I mean, traditionally we have patients presenting postmenopausal woman, especially if she's hypertensive, she's on diuretics and she presents with toe pain, we think in terms of gout in a patient. But in this case, okay, I'm getting a C there. Osteoarthritis में तो यार कोई joint aspiration में कोई crystal नहीं मिलेगा ना. Osteoarthritis will not have any crystals present. So anyway, C is off the radar. And because it's written the word negatively birefringent crystals, so I think the diagnosis will be laboratory based. No, negatively birefringent crystals would be found if it was pseudo gout in a patient. If it was pseudo gout in a patient, pseudo gout में knee joint involved होता है वो तो ठीक है, but then pseudo gout we have positive, no, weakly positive birefringence. We have positive birefringence. If the question is mentioning negative birefringence, we have to go in favor of gout in a patient. The correct answer for this would be option number A. I mean, knee pain is only given to confuse us. जैसे मैंने बोला कि gout में, even in a patient of gout, initially the joint that is involved will be the metatarsophalangeal joint, but then ankle and knee are also involved. Ankle and knee are also involved. So it's not that gout will not cause involvement of the ankle or the knee joint. Martel doc would be seen with chronic gout where we have erosions present. So Martel sign is erosions, and that's gonna be with respect to chronic gout. That's an old radiology MCQ of your FMG exam. It looks like a rat bite. The erosion which is present at the metatarsophalangeal joint and the bones adjacent to it, that would be looks like a rat bite, called as a Martel sign. The main point is knee is given as a distraction here. You need to rely on, okay, why not rheumatoid arthritis? Yeah, rheumatoid arthritis में तो हाथ के छोटे joints involved होते हैं ना. It is PIP, it is MCP, then it is wrist joint present, and this is not a crystal arthropathy. Rheumatoid arthritis does not have a crystal, and in this case there's a crystal arthropathy present, so that is why it is. And more importantly, sir, rheumatoid arthritis will be a young female, na? And यहाँ पे it's a postmenopausal presentation. Postmenopausal presentation होगा तो either you have to think in terms of osteoarthritis, old age है भाई, तो you have to think in terms of osteoarthritis in a patient, or you have to think in terms of gout in a patient. Gout का description सुनना मेडिसिन से, उससे clear हो जाएगा. Usually these patients end up with hypertension, and because of hypertension we put them on diuretics also. Because of the diuretics, the uric acid levels can spike. Thiazide देंगे इनको तो BP spike, BP control हो जाता है, but the uric acid levels tend to spike. Answer to 24 is option number A. Treatment is very confusing. Treatment for which one, doctor? I could not get it actually. Dr. Urmi, if you can just point it out. नीट में एक्यूट गाउट, हाँ जी डॉक्टर नीरज, वही चलो गुड आपने बोला सर. एक्यूट गाउट की खासियत ही यही होती है. एक्यूट गाउट की खासियत यही होती है, उसमें सीरम यूरिक एसिड नॉर्मल होता है. एक्यूट गाउट में, क्योंकि एक्यूट गाउट की प्रेजेंटेशन ही यही है कि यूरिक एसिड बढ़ता कहाँ पे है, तो ब्लड में नहीं बढ़ता, ज्वाइंट स्पेस में बढ़ता। अब नीट वाले डिस्कशन में देखना, उसमें फीवर भी था, तो बहुत सारे लोग सेप्टिक आर्थराइटिस भी बना रहे थे उसको। फीवर इज अ प्रेजेंटेशन ऑफ एक्यूट गाउट बिकॉज इन्फ्लेमेटरी स्टेट है। द हाईलाइट ऑफ acute gout is serum uric acid is normal because joint it gets precipitated in the joint of the in the joint. Rheumatoid arthritis in pregnancy. सर इम्यूनोमोड्यूलेटर जो भी चल रहा है वो कंटिन्यू करते रहेंगे। द ओनली थिंग इज कि भाई फर्स्ट ट्राइमेस्टर में आपको सिर्फ ड्रग्स को स्टॉप करना पड़ेगा, दैट्स द ओनली थिंग, राइट। तो यू कैन आई मीन स्टॉप अ कपल ऑफ ड्रग्स ड्यूरिंग हर फर्स्ट ट्राइमेस्टर ऑफ द प्रेगनेंसी. Sir, it will be available on my Telegram group, not on PrepLadder. Treatment for acute gout, sir, you'll not give allopurinol, man. For acute gout you don't give. For chronic gout you give allopurinol. For acute gout in a patient you have to give painkillers. Allopurinol is only for chronic gout in a patient. Acute gout, chronic gout, and with renal failure. For acute gout it is NSAIDs or steroids. अगर वो सिर्फ एक्यूट पूछ रहा है तो आप पेन किलर दे दो ना, इंडोमेथासिन दे दो, एस्पिरिन नहीं देना. ही विल से विच एनसेड इज कॉन्ट्राइंडिकेटेड. तो एक्यूट में एनसेड देते हैं, एस्पिरिन नहीं देते. अगर एनसेड से एलर्जी होती है तो स्टेरॉइड दे देते हैं. एंड इफ इट सेज क्रॉनिक गाउट इन अ पेशेंट देन इट इज एलोपेरिनॉल. फॉर ओवर प्रोड्यूसर अंडर एक्सक्रीटर होता है तो प्रोबेनिसिड दे देंगे. अगर रीनल फेलियर है फिर भी हम पहले एलोपेरिनॉल ही कंटिन्यू करते हैं. ओनली इफ द जीएफआर इज क्रिटिकली लो, only then we can switch over to febuxostat. Otherwise, even in chronic with renal failure, initially it's allopurinol. Only if the GFR goes down to 15, that's when febuxostat can be given. Colchicine will be used again in acute gout. The side effect would be diarrhea, so we usually do not give it in the first 1 to 2 days because अगर person को diarrhea करा दिया तो washroom कैसे जाएगा? पाँव में pain है. He's having a lot of pain in his foot. He can't even walk. He says even putting foot on the ground, I mean, I am crying in pain. And if we cause him a bit of diarrhea, going to the washroom to and fro will be a big problem for this patient. So we load him with painkillers, right? Give steroids if required. And raspberry sir is used in tumor lysis syndrome. Urmi, that pharma में बताते हैं. So it's gonna be raspberry case in gout. For raspberry case, you answer it only for case of tumor lysis syndrome, as has been asked in your exam. Tumor lysis syndrome with a high grade malignancy, what drug is going to be used? Then the answer should be given as raspberry case. So answer it for TLS and do not answer it for gout. Okay, coming to 25, this was a repeat question. This is anyway a repeat question session, so a lot of questions are repeat here. And he says cryptic का मतलब ये होता है difficult to diagnose. Cryptic मतलब जैसे cryptic code, cryptic language which is very difficult to decipher. So cryptic would be when the traditional tests are negative. When the traditional tests are negative in a patient, and in those circumstances, I mean the tuberculin test would be negative and chest X-ray in the patient will also be negative. Yes, the correct answer for 25 is beta. A negative tuberculin test and a negative chest X-ray, because traditionally whenever you are thinking in terms of TB, either X-ray will have a finding or tuberculin test will have a finding. Here both are negative, so it becomes relatively more difficult to diagnose. 25 is beta. Okay, I got a C there also. As I explained, cryptic मतलब यही है, difficult to diagnose. Okay, moving to 26. Yeah, it's a June 2021. Good that you are remembering even the year where the question has come. Very good. But subtle differences जो है ना, थोड़े से भी इधर उधर होता है तो आंसर्स गो रॉन्ग. मैंने फर्स्ट क्वेश्चन थोड़ा सा चेंज किया, सेकंड क्वेश्चन थोड़ा सा चेंज हो, दोनों के आंसर गलत हो गए, तो वो नहीं होना चाहिए. Okay. At patient presents with hemoptysis and hematuria, so the combination of this with anti-basement membrane antibody present would be answered by you as Goodpasture syndrome. In case they give you a question in which there is concomitant epistaxis is also given. Along with this, there is a hemoptysis. Along with this, there is a hematuria. And the X-ray of the patient can be showing multiple small cavities also. If this is the presentation given to you, yes, Goodpasture is type 2 hypersensitivity, but they can give you a question in which they can be epistaxis, hemoptysis, hematuria. Waiting for answers here. Very good. Your answer would be vaginous granulomatosis, which is currently called as granulomatosis with polyangiitis. and had I written the word Cianca anywhere, this would have been easier for you guys. So that is why I waited for a few seconds to write Cianca, and I'm really happy that even without me writing Cianca, you were spot on in your answer. Vaginous as a word has been removed from medical literature, so you will say GPA, granulomatosis with polyangiitis. Good one anyway. So we started with 26. Answer is beta. In case you get this epistaxis, that is upper respiratory tract, lower respiratory tract, and the lung involvement, then it is granulomatosis with polyangiitis that is to be considered. Moving to 27. Dr. Iqbal, for high grade malignancies, if you can go through the previous discussions, great. Otherwise, I'll solve it for you in 15 seconds. If it is a high grade malignancy like Burkitt's lymphoma, acute lymphoblastic leukemia, because the tumor load is very, very high, the turnover rate of the cancer is very high, we should go for raspberry case. If it is a moderate grade malignancy, then we go in for allopurinol. There's a table that I've described in even in FMG solutions book. The table is given. Otherwise, the solution is only one. Usually, they'll give you a scenario: patient, child with malignancy. Commonest tumor in children is ALL, or the child with jaw swelling, Burkitt's lymphoma. So even if it does not write the name Burkitt's lymphoma or does not say acute lymphoblastic leukemia, you need to extrapolate the data. Child लिखा है तो भाई high grade malignancy होती है बच्चों में. So for that, raspberry case would be the best answer. So I hope Dr. Ashik, I was able to answer you there. And then we are having a very severe headache with nuchal rigidity. And every time we get a combination of headache with nuchal rigidity, we are to think in terms of subrectal hemorrhage in a patient. That worst headache of my life may or may not be written. That thunderclap headache may or may not be written. I mean, every time we have headache with nuchal rigidity, we have to think in terms of subrectal hemorrhage in a patient. And in these patients, the following investigations need to be done. You guys can tell me the investigations that need to be done. If he says initial investigation, like he may not say what is the diagnosis, he may say what is the first investigation. Why answer is not C and D is because C and D will be having fever. I'm waiting for the comments for the investigation. For chronic migraine, there should always be a pulsating or a throbbing headache present. So considering the fact that pulsating headache, throbbing headache is not given, then option B is unlikely. Yep, we'll do a CT. Okay, non-contrast CT head that will show presence of blood in the sylvian fissure. We can do a CT angiography in a patient subsequently because there can be more than one berry aneurysm in a patient. And most of the time on the basis of the combination of this, then the treatment of the patient can be done. What is the treatment of choice for this patient? Yes, guys. If CT, no, don't answer lumbar puncture या raise IC पे avoid करते हैं ना. So lumbar puncture is usually avoided because there is a raised ICP. If we do not have a CT angiography or a non-contrast CT scan, तब lumbar puncture करते हैं. That lumbar puncture will be having xanthochromia. If it is done after 48 hours, it will be having xanthochromia, which would mean that there would be a bilirubin in the CSF of the patient. Nimodipine is the drug of choice, ना treatment of choice नहीं बोलना है. Treatment of choice नहीं बोलना. Treatment of choice for this patient would be endovascular coiling. The treatment of choice is endovascular coiling, and the drug of choice जो है that is to be answered as nimodipine. तो सीधा नहीं बोलना. Mannitol तो सर देते ही हैं, raise ICP है तो ठीक है, but in active CNS bleeding mannitol से फायदा नहीं होने वाला ना. If there is a ongoing bleed तो mannitol नहीं दोगे आप. You get confused nifedipine and nimodipine. तो सर आप nimodipine याद कर लो. Nifedipine को यूज नहीं करते because वो sublingually देने से unpredictable fall in BP होता है. So we would like to give a drug which causes a more predictable fall in blood pressure. It is nimodipine, NIMO, not nifedipine. It is nimodipine which is used. Treatment is endovascular coiling. For medical management, we give nimodipine because of the fact that nimodipine will prevent the vasospasm of the surrounding areas. Yeah, if it is a berry which is located, let me say, in the cavernous sinus. Internal carotid artery traversing the cavernous sinus, then visual problems can also occur. Why mannitol not given in ongoing bleed? तो उससे क्या होगा यार कि the bleed will worsen because if you give mannitol when the bleed is ongoing, so you are gonna shrink the tissue of the brain and that will create more space for the bleeding to occur. So anyway, the basic rule is whenever there is an ongoing CNS bleed, we do not give mannitol. Mannitol is given for mass effect, no? When suppose there's a bleed and the bleed is producing a mass effect से मेरा मतलब posturing हो रही है. If a patient is having a CNS bleed, like उसको brain hemorrhage हुआ, brain hemorrhage के तो उसको posturing start हो गई, that is when we give mannitol to the patient. Otherwise, for a person who's had a brain hemorrhage, the main treatment to lower the pressure would be a ventriculostomy. That is a more accurate way to decrease or lower the intracranial pressure in a patient. So mannitol is only to be used for a mass effect. If there is a bleed producing a mass effect, like it is contributing to posturing in a patient. Otherwise, we will do ventriculostomy in a patient, which is much better. Answer to 27 is option number A, plus these additional aspects that I mentioned is perfectly fine. Hemorrhagic CV आता है तो usually we give mannitol. नीरज, we give mannitol जब उसको पोस्टरिंग हो जाती है रेज एसिपी की वजह से, जब उसको ऑनगोइंग एक्टिव ब्लीड हो रहा है ना, जैसे मान लो किसी को वारफेरिन टॉक्सिसिटी की वजह से एक्टिव सीएनएस ब्लीडिंग हो रही है अभी, तो आप उसको मैनिटॉल नहीं दोगे. अगर हाइपरटेंशन की वजह से उसको ब्लीड हो गया और वो ब्लीड अब थोड़े टाइम बाद स्टॉप हो गया टैम्पोनर डिफेक्ट की वजह से, तो वंस इट स्टार्ट्स कॉजिंग डेवलपमेंट ऑफ पोस्टरिंग इन अ पेशेंट, तब मैनिटॉल देते. अदरवाइज मैनिटॉल मत देना, आप वेंट्रिकुलोस्टोमी करो. जो अब वो बात अलग है कि यू कैन से दैट इन गवर्नमेंट हॉस्पिटल फैसिलिटीज आर लेस एंड स्टफ लाइक दैट. कोर्ट विल नॉट एग्री टू दैट. कोर्ट विल से यू शुड हैव हैड द बेस्ट फैसिलिटीज अवेलेबल. नीरज, सिनेरियो इज वारफेरिन, no? If there is a warfarin toxicity happening, then the bleed occurs over hours. Whereas if it is a hypertensive patient or cerebral amyloid angiopathy, then, और एक और आपने क्वेश्चन पूछा कि ऑनगोइंग ब्लीड कैसे पता चलती है, सीटी रिपीट कर लो ना. अगर हेमाटोमा की वॉल्यूम इंक्रीज हो गई तो इट्स अ ऑनगोइंग ब्लीड इन अ पेशेंट. सीटी करने में तो फ्यू मिनट्स ही लगते हैं. सो आप इवेलुएट कर सकते हो, दोबारा सीटी करो, ब्लीड इंक्रीज हो जाएगी. Okay, which of the following is best used for the medical management of this condition? In this case, there was a CT angio given, and in CT angiography, you can notice a tennis ball appearance here. Since there's a tennis ball appearance which is present here, we're gonna get this as aortic dissection. And because the diagnosis of this patient is a aortic dissection, so we have to manage the high blood pressure of this patient. Yes, for medical management of this patient, because leading cause of aortic dissection is high blood pressure, so need to control hypertension and plan surgery. This would be a type A aortic dissection because ascending aorta of the patient is involved. So this is a type A aortic dissection, and for any patient having a type A aortic dissection, we need to control the high blood pressure and plan a surgery in the patient. So yeah, wait and watch में तो patient will anyway die. We are having a CT angiography, so there is no need for an MRI. And send home is a very outrageous statement. I mean, I double checked with students कि भाई सच में ये लिखा था क्या? Oh, I mean, this was actually one of the option. Yeah, we do get an I mean tearing type of pain present here. Labetalol, doctor, would be answered only for type B aortic dissection. Labetalol only in type B aortic dissection, and that too if the patient is hemodynamically stable. Yep. Otherwise, we will not use labetalol. Okay, moving to the next one. A 40-year-old man with a 15-year-old history of smoking 10 cigarettes per day presents with episode of hemoptysis. So, I mean, hemoptysis in a smoker, I'm thinking in terms of a lung cancer. Chest X-ray shows a mass near the apex of the patient, and he says, what is the next best step for management of this patient? The basic concept is that every time we are having a lung cancer, it can be a central lung cancer or a peripheral lung cancer. Adenocarcinoma is peripheral and squamous cell and small cell is central in location. So what you need to do is just get this fact right. In case they give you scenario of a squamous cell cancer or of a small cell cancer which is central in location, then we have to go in for a bronchoscopic biopsy in the patient. Then we have to go for a bronchoscopic biopsy. But if it is a peripheral cancer like a adenocarcinoma which is located at the apex, I mean, how do you know it is peripheral? Either it should be near the pleura like given in this question, or it should be near the apex of the patient. So any of the two situations, either it is written near the pleura or it is written near the apex, then we can go for a CT guided transthoracic biopsy in a patient. The correct answer in this particular case would be to go ahead with the tissue diagnosis. I mean, biopsy is anyway to be done because you need to confirm the tissue diagnosis, and only then the subsequent treatment of the patient can be done. Bronchoscopic biopsy not recommended for this case in a sense that this was a peripherally located tumor. Yep. The answer to this one is option number A. So we move to the next one. This lady is having a history of taking OCP and headache for last 6 months, which worsens and recumbent and improves as the day progresses. So there's a diurnal variation of headache given. There's no pulsatile, because normally in a female, I'm thinking about migraine, and he has mentioned about OCP also, which causes weight gain. The most important point to solve this MCQ is this word papilledema. Raise ICP का feature होता है, and MRI also shows a raised ICP. It says what is the diagnosis. So Myasthenia gravis anyway presents with ptosis and diplopia, so that is out. Temporal arteritis will not have a papilledema. I mean, B and C can be ruled out in this case because there is no papilledema seen in migraine. There is no papilledema seen in temporal arteritis, which is the extracranial cause of a headache. So the answer for this question would be option number A, that is pseudotumor cerebri. Pseudotumor cerebri can be seen with drugs, like in pediatric age group. Most of the time in pediatric age group, pseudotumor cerebri is seen with vitamin A toxicity, and pseudotumor cerebri would otherwise be seen with OCP usage or even with sudden steroid withdrawal. So these are the usual scenarios that can be seen for which pseudotumor cerebri can be given in the question. Answer to this is option number A. Yeah, Niaz, you gave a lot of good inputs there. Expiry date, tetracycline, vitamin A. There are a couple of other risk factors which are present. But then pseudotumor cerebri per se is a condition which means increased pressure in the brain without change in the size of the ventricles, because hydrocephalus में दोनों change होते हैं. In hydrocephalus, the size of the ventricle will also increase, pressure will also increase. Here only pressure is going up. Size of the ventricles is normal. I repeat that again. In hydrocephalus, you have increase of both the size as well as the pressure of the ventricles. Here the size of the ventricles is normal, pressure is normal. It's usually triggered by drugs. In pediatric age group, it is excess of vitamin A. In adult age group, it will mostly be the sudden steroid withdrawal or tetracycline or OCPs. And papilledema is ruling out chronic migraine and temporal arteritis. Temporal arteritis will cause a burning pain on the side of the head. The key word for temporal arteritis would be temporal headache. And another feature that would be seen for temporal arteritis would be age group of the patient. That would be more than 65 years of age. Mostly is a geriatric presentation and presents with a temporal headache. We sorted with 30, so we still have a couple of more to go. Let's be a little faster in these. We have a patient who's presenting with ptosis, muscle weakness, which increases at the end of the day and gets relieved with neostigmine. Can't be an easier question with this. He has himself given you diurnal variation of weakness. He has mentioned improvement with the neostigmine, so our answer would be given as Myasthenia gravis in this case. And you guys have to quickly tell me, if it's a two-step question, what is the treatment of choice for this condition? Yes, guys. Okay, hydrophonium for diagnosis, no, that is not the case. So question is open, then investigation of choice. What is the preferred electrodiagnostic test for this condition? Nowadays, we do not go for hydrophonium. Rather, we use a ice pack test for these patients, which has been a question of the previous year. So hydrophonium is not used. Hydrophonium is only used if the antibody tests are negative for this patient. Hydrophonium is not used anymore, sir. We use ice pack test. And what is the electrodiagnostic test done? So we go in for a single fiber electromyography. The electrodiagnostic test for this condition, the best electrodiagnostic test for this condition is single fiber electromyography. The advantage of doing thymectomy is it will reduce the requirement of immunosuppression. Steroids are anyway given for these patients. Mycophenolate would be used, azathioprine would be used. So immunomodulators are going to be used because this is an autoimmune condition. The advantage of doing thymectomy will be it will reduce the requirement. It will reduce the requirement of steroids. Like patient कहता है मुझे नहीं कराना operation, तो not an issue by steroid high dose में खाओगे side effects होंगे. So the only advantage of doing thymectomy is to reduce the need for immunomodulatory drugs. Electrodiagnostic test is a single fiber electromyography. And only if all the tests are negative, electrodiagnostic test is negative, ice pack test is negative, antibody test is negative, only then you go for hydrophonium test. I repeat that again. If electrodiagnostic test is negative, ice pack test is negative, and antibody test are negative, only then you go in for a diagnosis of myasthenia gravis with the help of a tensilon test. Yes, guys. for this particular condition, please tell me the name of antibodies here. It is anti-acetylcholine receptor antibody. What other antibodies do you read here? Anti-acetylcholine receptor antibody, then we have anti-MuSK antibody, then we have anti-LRP, that is lipoprotein receptor 4 antibody. So these are a couple of antibodies which are encountered here. There are actual 6 antibodies in Myasthenia gravis, but I want you to know at least 3: anti-acetylcholine receptor, anti-MuSK and anti-LRP4 antibodies. Myasthenia gravis has a speciality that there is a muscle weakness. It's a pure motor disease but has normal deep tendon reflexes. It's a pure motor weakness. There is no sensory involvement in this condition, and the reflexes are normal in this condition. Answer to 31 is beta. Lambert-Eaton syndrome is a differential of it. In Lambert-Eaton syndrome, the antibody name is different. The name of the antibody in Lambert-Eaton syndrome is anti-PYQ antibodies, which are against voltage-gated calcium channels. Lambert-Eaton is a pre-junctional defect. उसमें anti-PYQ antibodies present होती हैं. These anti-PYQ antibodies, just zooming it out a bit, anti-PYQ antibodies would be acting against the pre-junctional voltage-gated calcium channels, and they will reduce the amount of acetylcholine produced at the neuromuscular junction. The clinical features of Myasthenia gravis can be same as that of Myasthenia gravis. Lambert-Eaton syndrome can be same as that of Myasthenia gravis. The difference will be only कि वो eye weakness से start नहीं करेगा, वो arm weakness से start करेगा. The question will begin with the arm weakness, then we'll go on to talk about eye weakness, and the antibody name will be what I've written, anti-PYQ antibodies, which help in diagnosis. Lambert-Eaton का drug of choice बताओगे मुझे? Yes, it is associated with lung cancer. Lambert-Eaton का drug of choice बताओगे? Yes, guys. Preferred drug for management of Lambert-Eaton syndrome. Waiting. Very good. Niaz was the first one to comment there. Spot on. 3,4 aminopyridine. Yes, we can use pyridostigmine also, doctor, but first answer would be 3,4 aminopyridine, which would be a potassium channel. This will regulate the potassium channels and will improve the depolarization at the neuromuscular junction. Yes, I think the slide is better now. Okay, so Myasthenia gravis is what I've tried to summarize there with respect to the investigations that are done, the treatment that is done, and the name of the antibodies that you guys should be familiar with. 31 is sorted. We come to 32. What is the preferred management for a person with acromegaly? Yes, deep tendon reflexes are absent, doctor. In Lambert-Eaton syndrome, the reflexes are absent. Dr. Asik asked, in Lambert-Eaton, deep tendon reflex is present? No, it's not present. It is hyporeflexia. Acetylcholine release ही नहीं हो रहा ना यार. Preferred management for acromegaly, this would be a pituitary tumor causing excess of growth hormone. And once the pituitary tumor is having excess of growth hormone production, we have to shrink the tumor. So we have to give lanreotide in this patient. This is to help in shrink the pituitary tumor. We might have to go for surgery subsequently, that is transvenous surgery, but initially to shrink the pituitary tumor, it's lanreotide, which is a long-acting version of octreotide to be used. The next question says, which of the following is a feature of hemolysis? The RBCs are bursting, and once the RBCs will burst, octreotide is also given, doctor. Absolutely yes. But then on a comparative basis, no. If I have to give a regular octreotide infusion versus depot injections of lanreotide, then person will say कि sir मतलब injection लगा दो जो मतलब रोज hospital ना आना पड़े. So octreotide infusion is something which would not be very comfortable for a patient. Okay. Yeah. See, doc, we have lot of options available for management of these patients. Cabergoline, bromocriptine are to be answered for prolactinoma. Somebody mentioned cabergoline, Virender, that would be for a prolactinoma. At the moment, we're talking about a tumor that is having excess of growth hormone. Moving to 33, he says, which of the following is a feature of hemolysis? So every time there is gonna be, RBC is gonna burst, so free hemoglobin is gonna be coming in the circulation. and this free hemoglobin will bind to haptoglobin. I mean, haptoglobin is like a mop which will help and bind to free hemoglobin. Otherwise, this free hemoglobin will block the tubules of the kidney. I can have a renal failure in a patient. So, the RBC bursts, the free hemoglobin is bound to haptoglobin, and therefore the haptoglobin levels will reduce in this patient. Option number A is wrong. It is not a decreased LDH, it is an increased LDH that can be happening. Similarly, hemolysis causes reticulocytosis and causes unconjugated hyperbilirubinemia. I mean, for C, it should be cytosis. For D, it should be unconjugated hyperbilirubinemia. And for option number A, it should have been increased LDH, but he deliberately just mixed that MCQ writing increase, decrease options there. Okay, cool. Yes, Neeraj, you helped me with that. Coming to 34, we are having a patient with abdominal pain episodes, recurrent renal stones. I mean, the moment you read recurrent renal stones and abdominal pain, moaning, groaning in a patient, you are thinking in terms of hyperparathyroidism. Plus, he has himself mentioned, he has shown a lytic lesion. He said this is suggestive of a brown tumor, and you read brown tumor with hyperparathyroidism. So there could be a tumor in any one of the parathyroid glands, and I want to pick up this tumor. So to pick this up, I would be doing a radionuclide scan, that is a Sestamibi scan. The correct answer for the current question on the slide 34 is option number C. Technetium 99 Sestamibi scan helps you in identifying a parathyroid adenoma. I mean, the same question was asked in NEET PG one-liner. Here he has just tried to be a little descriptive by describing recurrent renal stones, obviously because calcium goes up, so recurrent renal stones in the patient, constipation that can explain recurrent abdominal pain episodes, plus renal colic would anyway be there. Yep. The treatment for this would be a surgical resection of the tumor, plus we'll have to manage hypercalcemic crisis. You can answer me first line management for hypercalcemic crisis and drug of choice for hypercalcemic crisis. Two questions before you, quick answers, next 15 seconds. First line management for hypercalcemic crisis, drug of choice for hypercalcemic crisis. Let's say in this patient calcium jumps up to 13, goes up to 14. If the calcium goes up to that higher level, there's a probability that the person can land up in systolic arrest of the heart. I don't want to take a chance. So the first line management would be normal saline. No, it's not calcitonin. First line is dilution. No, all endocrine emergencies, first line management is always normal saline. For all endocrine emergencies, first line management is always normal saline. And then we can be using bisphosphonates for this patient. So like we can be using ibandronate or zoledronate. So I mean, bisphosphonates are to be used as the drug of choice, and the first line management would be normal saline. Hydration is a good way to explain that. Okay, moving to 35, we have a 60-year-old patient who has presented with a throbbing unilateral headache, nodular thickening around the temporal artery. I think that's the key pickup in the question, nodular thickening around the temporal artery, and there's giant cells which are present in the granulomatous vasculitis. So I think he's given a pathological diagnosis. He has mentioned even the location of the lesion. And again, a very simple question here. The correct answer for this would be temporal arteritis. Why this is not Takayasu's arteritis is one, because Takayasu's usually would be causing the involvement of Takayasu's arteritis would be causing commonly involvement of the subclavian artery and presents as pulseless disease. Most of the time it's the subclavian artery gets involved. The clinical presentation of this condition would be a claudication. This would be a vascular claudication. Like arm claudication is one of the reasons why patients of Takayasu's arteritis would come to you. Repeated use of the arm will cause pain in the arm because blood supply is getting compromised. There is a narrowing of the ostia. Another reason Takayasu's arteritis patients can come is because of very high blood pressure. They might be having daily headaches. They might think they're stressed out at work, and turned out that the ostia of the renal artery is narrowed. So, I mean, two presentations of Takayasu's arteritis are arm claudication and then renal artery stenosis presenting with hypertension. Burgess disease will again present, but it would be a question of smoker with intermittent claudication. This question would be having the pain in the legs on walking, pain in the toes on walking, pain in the calf on walking, and subsequently toe gangrene will occur. I clarify once again, the pain will be in the calf and in the foot, and there would be a distal gangrene developing in a patient. Correct answer for this one is beta, temporal arteritis, called as giant cell arteritis. It's called so because on biopsy you get giant cells with granulomatous vasculitis. Okay, moving to the next one. Jaw claudication would be present, absolutely. Okay, we have a 19-year-old guy presenting with jaundice. LFT shows an unconjugated bilirubin which is elevated, and then this normal AST, normal ALT, normal SAP, and past medical history is significant for evidence of recurrent episodes of jaundice since birth. He is asking about the commonest congenital hyperbilirubinemia, and I think you guys can answer it. The commonest hyperbilirubinemia that we encounter would be Gilbert syndrome. Absolutely. There would be a decreased activity of UDP glucuronide transferase. That's why the icterus is present. And Crigler-Najjar will usually have a neonatal presentation. Crigler-Najjar can present even with kernicterus if there's a complete absence of the enzyme UDP glucuronide transferase. And Dubin-Johnson will present with conjugated hyperbilirubinemia. Whereas in this case, the presentation given is that of unconjugated hyperbilirubinemia. So that is why the correct answer is present. Absolutely, absolutely right, Abhishek. Ashik, you're right. Most guys have got this one right again. Good. Once we are done, do comment in the chat box regarding how many you got correct out of these, and I expect 100% strike rate for all those that I'll be discussing. Okay. A smoker has presented with a blood-tinged sputum during cough, and on workup, the chest X-ray of the patient is normal. Can be, if the lesion is small, then the X-ray can be normal. He says, what is the next step to be done in a patient? So I need first an anatomical diagnosis. I need to find where is the lesion present. I'm suspecting a cancer in a smoker who's having blood-tinged sputum with cough, or they can be bronchiectasis also, which can present with blood in the sputum, but I need an anatomical diagnosis, where is the lesion present. So what I'll do in this case would be, I got a sputum chest as an answer. Guys, you are, suddenly in between there is lapse of reason. The correct answer for this one is a CT chest. There's a clear-cut flow chart which I want to show here in case there is a life-threatening hemoptysis. If he says massive hemoptysis in the exam, and massive hemoptysis would be given for presentation of TB, where the source of bleeding would be the bronchial artery. So in this case, if it's a massive hemoptysis, you have to go in for protecting the airway of the patient initially, but then he will most of the time be asking you what is the treatment for massive hemoptysis. So for life-threatening hemoptysis in a patient, you have to answer as bronchial artery embolization. Answer it as bronchial artery embolization, which is the main treatment to be offered for massive hemoptysis. If it is a non-threatening hemoptysis in a patient, after the X-ray, the next investigation to be done is CT scan. Why? Because if I straight away do a bronchoscope, तो मुझे पता कैसे चलेगा कि lesion is on the left side or the right side, upper part or lower part, and the right side has upper lobe, middle lobe, lower lobe. So I need to send the bronchoscope in that area where the supposed lesion is present. For that I need an anatomical overview of the lung, and that is why CT scan should be done first, so that subsequently I can proceed with bronchoscopy in a patient. So if he talks about a non-life-threatening hemoptysis in a patient, then it is a X-ray, then is a CT, then is a bronchoscopy. Why first a CT? Because आपको पता कैसे चलेगा कि bronchoscope left जाना है या right जाना है. Anatomical localization of the lesion is important, which is why first. But on the right hand side, we straight away go ahead with the a bronchoscopy and a rigid bronchoscopy, in fact, and then subsequently a bronchial artery embolization, interventional neurology, radiology procedure will be done. That's a bronchial artery embolization. Answer to 37 is option number C. Yeah. Moving to 38, a man presents with 18-year-old history of exposure to asbestos. And anyway, if a person is having exposure to asbestos, he could be working in construction business, shipbuilding. So in those scenarios, he can be developing two problems. Either he can develop adenocarcinoma of the lung, or he can develop a mesothelioma. I mean, the biggest problem with these patients would be mesothelioma, which will have two issues. One, mesothelioma will cause a pleural plaque calcification, and second, it can cause a bloody pleural effusion. These are the two situations which can be asked for mesothelioma: bloody pleural effusion and pleural plaque calcification. बाकी तो asbestosis causing development of mesothelioma is not a big deal. Yep. Okay, 38 is sorted. If he says most common cancer in asbestosis, if he says which is the most common lung cancer in asbestosis patient, the answer is still to be answered as adenocarcinoma. If he says specific, then it is okay. I mean, specific is mesothelioma, but he says overall cancer in asbestosis, the answer is still adenocarcinoma. Has been asked earlier, commonest cancer in a chap with asbestosis. The answer is not mesothelioma, it is adenocarcinoma. Okay, ji. Black everywhere, black screen. Okay. Yeah, it was good, doc. It's a beautiful place. Moving to 39, a 70-year-old patient presents with sudden onset chest pain, and the ECG of the patient is given. I'll zoom into the ECG because it would be little so smaller. And when you look at the ECG of the patient, as I've told you multiple times, any question that begins with chest pain, always in the exam, look at 2-3 AVF and then look at lead number V1 to lead number V6. And in lead number 2, lead number 3 and lead number AVF, you would be able to pick up that classical ST segment elevation present, which is helping you know that you're dealing with a patient having an inferior wall MI. I would also like you to notice that there is a reciprocal change. You can notice a ST depression that is occurring here with respect to lead number V1 especially. I mean, in lead number V1, you can pick up a reciprocal change present. Majority of my changes are located in lead number 2, 3 and AVF. So this is again a repeat question and would be answered as inferior wall myocardial infarction. Yes. And if I count the heart rate of this patient, I can count, I'll use a finer pen. I can count about 3, 4, 5. So the heart rate of the patient is little on the lower side, about 60 per minute, and that's because in inferior wall MI, vagus nerve gets activated. So that's why bradycardia component can be present. Answer to 39 is option number B. For anterior wall myocardial infarction, the findings will be present in lead number V1 to V4. For posterior wall MI, the findings will be present in V1 to V4 as well as V7, V8, V9. Both should be present. And for pericarditis, it is ST elevation concave and should be all the leads. In this case, because the findings are present only in 2-3 AVF, that is why it is an inferior wall myocardial infarction. Next, we are having a patient of sarcoidosis who's presenting with nausea and vomiting. PSVT, unstable patient, treatment of choice is cardioversion, doctor. Asik Iqbal asked, what is the treatment for PSVT unstable patient? It is cardioversion, DC shock. Okay, troponin I is anyway to be done. The biomarkers are elevated in these patients. We have a sarcoidosis patient who's presenting with nausea, vomiting. Serum calcium is elevated. Normal is 9 to 11. In this case, the serum calcium is jumping up to 12.5, and he's saying which of the following will be least useful for management of these patients. So we will give normal saline. Steroids are the treatment of choice for sarcoidosis. Steroids are the treatment of choice for sarcoidosis, and bisphosphonates will be used because they will help in treating the elevated serum calcium level as we have discussed. So B, C and D will be used. What is not going to be helpful is fludrocortisone or mineralocorticoids for the patient. There is no role of mineralocorticoids in management of hypercalcemia. The concept behind this question was management of steroid responsive hypercalcemia. The best example of steroid responsive hypercalcemia is sarcoidosis. Though there are multiple examples including exogenous steroids, but then the best example for steroid responsive hypercalcemia is sarcoidosis. Okay, one more question on calcium metabolism that I would like you guys to answer me here is, which lung cancer causes hypercalcemia? Lung cancer contributing to hypercalcemia. वॉमिटिंग है तो डिहाइड्रेशन, हाँ जी होगा डिहाइड्रेशन होगा, बट डिहाइड्रेशन के लिए मिनरलोकॉर्टिकॉइड नहीं दोगे ना, फ्लूट्रोकॉर्टिसोन नहीं देंगे। ये एडिसन डिजीज का मरीज नहीं है ना कि मैं उसको मिनरलोकॉर्टिकॉइड दूंगा। एग्रीड, वॉमिटिंग विल कॉज डिहाइड्रेशन, उसके लिए फ्लूइड दे देंगे ना सर। यस, द आंसर वुड बी स्क्वेमस सेल कैंसर, नॉट स्मॉल सेल, it is squamous cell cancer. Squamous cell cancer will produce PTHRP, parathormone related peptide. It will produce PTHRP, that is parathormone related peptide, and that PTH related peptide would then contribute to hypercalcemia in the patient. So answer to the query that I have raised up is squamous cell cancer. Great. And yep, answer to 40 is alpha. PTHRP, great, related peptide. So guys, we are back to now to the last 10 questions for today. So let's see how fast can we do them. I am having a chronic liver disease patient who's presented to the OPD with fever and gross abdominal distension. That basically tells me that this chronic liver disease patient is having ascites. The point of concern is there is fever in the patient, which normally should not be there. And नहीं, वो आप मैं बताता हूँ गलती क्या होती है कि ये जो होता है ना स्मॉल सेल वाला, वो स्मॉल सेल लंग कैंसर बनाता है ACTH और एंटी डायूरेटिक हार्मोन, तो हमें लगता है सब कुछ स्मॉल सेल आंसर करना है। स्मॉल सेल सिर्फ दो ही जगह आंसर करना होता है, ACTH के लिए ना, कुशिंग सिंड्रोम एंड SIADH के लिए। कमिंग बैक टू 41, CLD पेशेंट इज हैविंग ग्रॉस एब्डोमिनल डिस्टेंशन, इट इज ascites, बुखार आ रहा है, दैट इज अ कॉज ऑफ कंसर्न, एंड बिकॉज देयर इज अ टेंडरनेस इन द एब्डोमेन आल्सो, सो आई थॉट यार कहीं इन्फेक्शन ना हो गया। So ascitic fluid is revealing 500 cells per cubic millimeter. So the diagnosis of this patient is spontaneous bacterial peritonitis. Traditionally, peritonitis occurs whenever there is a rupture of intestine, when there is a viscous perforation. But in this case, there is no viscous perforation. That is why we are calling it spontaneous. In this condition, there is a migration of bacteria, transmigration of bacteria from the gut, from the lumen of the gut into the ascitic fluid, because ascitic fluid is rich in nutrition. So the bacteria migrate from the gut wall via the lymph nodes into the ascitic fluid and cause spontaneous bacterial peritonitis. And once he is having this spontaneous bacterial peritonitis, I need to manage the patient effectively. I need to treat the infection. The answer to this question, I mean, initially I did get option as C, I got even B also. तो चलो मैं सॉल्व कर देता हूँ। अगर तो सपोज इन दिस MCQ, सपोज द क्वेश्चन वाज आस्क्ड एज व्हाट इज द मैनेजमेंट फॉर हिपैटोरेनल सिंड्रोम, देन फॉर हिपैटोरेनल सिंड्रोम वी गिव एल्ब्यूमिन एंड मिडोड्रिन। इफ द क्वेश्चन वाज रिटन एज रिफ्रैक्टरी ascites, like we have given maximum dose of spironolactone, we have given maximum dose of furosemide to this patient, we have maxed out on the amount of diuretics used, and still the person is having ascites, then we go for a large volume paracentesis in a patient. तो A और B तो बनता नहीं है। ऑक्ट्रेटेडम देते हैं जब पेशेंट को ब्लीडिंग वराइसिस होते हैं, तो वैसे भी इन्फेक्शन की बात कर रहे हैं ना, तो फॉर द इन्फेक्शन वी एनीवे हैव टू गिव टू द पेशेंट सेफ्ट्रिऑक्सन। द करेक्ट आंसर फॉर क्वेश्चन नंबर 41 is option number D. The key words in the question were that you had to pick up Indian forces. No, I am not related to the forces. I know a lot of doctors who have been my students and have worked in the army medical course, and then I know a lot of people in my family who have worked in the Indian army. So that's the only thing I know about the hardships. I have not worked with forces. Okay. The answer to this question is IV ceftriaxone, because there is a spontaneous bacterial peritonitis which is developing in this person. There is an infection present, and that is caused by E. coli. So I need to handle the bad guys with antibiotics only. Remaining options, where would they be answered? I've already explained here. Answer to 41 is delta. We come to 42. Okay, tall T waves, then wide QRS and a prolonged PR interval. Basically, what is happening is heart is becoming slow. Wide QRS return, prolonged PR interval. So there is a slowing of the heart, and slowing of the heart can be seen with potassium. Most of the guys can pick up this question by the word tall T waves, which is a standard feature that is seen with hyperkalemia. Answer to 42 is option number B. Question to you guys now is, what is the drug of choice for hyperkalemia? Options are calcium gluconate, insulin drip. Tell me the drug of choice for life-threatening hyperkalemia. Potassium value of the patient is going up to 8 milliequivalents. What is the treatment for life-threatening hyperkalemia? Options, I repeat again, calcium gluconate 10%, insulin drip, select one. Okay, I'll wait for a few seconds for people to comment here. Okay, I'm getting an insulin, calcium gluconate. So I knew that this is gonna occur. I'm even gonna get a patiromer, which I did not give in the options. Patiromer is for chronic hyperkalemia. Yes, we'll be giving calcium gluconate, sir, for life-threatening hyperkalemia, because the heart will stop in the next couple of minutes. So you need to do antagonism of elevated potassium, and therefore you need to give calcium gluconate to the patient. Now, suppose I change this MCQ and the question is, what is the drug of choice to lower, what is the preferred drug to lower elevated potassium? If I change the language of the question to what drug would be given to lower elevated potassium, in those cases, fine, the efficacy would be of insulin drip, because insulin drip will cause about 0.5 to 1 milliequivalent fall in 1 hour. So if the question is about how would you lower the elevated potassium, then insulin drip is a good answer. But since I did not give you that question, I asked you how do you manage life-threatening hyper-K, then the answer should be given as calcium gluconate. So just pay attention to the words which are always asked in the exam, because what I can assure you is, for any exam, that's true for any exam, whether it's a NEET, PG or FMG exam, it is not lack of knowledge, it is lack of application that can cause it. So my suggestion is, try to minimize on the negatives. I mean, for you guys, the negative count will not matter, but in a sense that you don't have a negative score coming up, negative subtraction from your total score. But then, if a couple of questions go wrong with silly answers, then I mean, we can have a pretty nasty situation of that 150 versus 149, which should not be happening. So again, the point is, you all are brilliant chaps. It's not lack of knowledge, it's lack of application. That's always a cause of error. So try to always keep that in mind. Yes, doctor, we will add. Neeraj, हम यहाँ पे insulin drip में ना add करेंगे. This insulin drip will be with 25% dextrose ना. अगर आप सीधा इंसुलिन दे दोगे तो इतना कम होता है, 10 यूनिट देना है तो 10 यूनिट तो अमाउंट इतना कम होता है कि वो कैनला में ही रह जाएगा ना. तो वी मिक्स इट विद 25% डेक्सट्रोज एंड गिव इट इन द फॉर्म ऑफ अ इन्फ्यूजन. यस, 25% डेक्सट्रोज वुड बी हो गया. साग ग्रेडियंट, सर आसिफ, बिकॉज वी आर डूइंग दिस फॉर क्वेश्चन सेक, बट साग के लिए ना मैंने एक आरआर में डिस्क्राइब किया हुआ है, निमोनिक बताया हुआ है, सैग मोर देन 1.1 और लेस देन 1.1 के लिए. And I mean, if I get into that, it will change the entire domain. So my request is, just have a look at that. If you're still not able to figure it out, ping me at marwahmedicine@gmail. I'll try to simplify things. But otherwise, it's very simple, straightforward, but takes about 3 to 4 minutes to explain the entire SAG concept. Answer to 42 is beta. We come to 43. Patient is presented with features of cardiac tamponade, and which of the following is a true finding? A very interesting, and I would rate it as a difficult question that came. Pulsus paradoxus is always present. Now, if it is a low pressure cardiac tamponade, while it is developing, pulsus paradoxus may not be present. So that always, यहाँ पे the always word is something which I am a little afraid of. So I am saying, okay, this may be the answer, may not be the answer. So I'm putting a plus minus in front of it. Small sign is always present. This is a wrong statement. Small sign is absent in a patient of cardiac tamponade. We discussed that even in the earlier part of the discussion today. Tall A wave present. Rather, in cardiac tamponade, there is no filling. There is no filling of the heart. There is an impaired filling. So I can rule out two options directly. tall A waves नहीं होते, यहाँ पे rather जो finding मिलता है that is a absent Y descent because there is no filling, and if there is no Y then there can't be a A also, because if there is no filling there would be no subsequent waves present. But D says jugular vein column is visibly distended without pulsations. One of the highlight of cardiac tamponade in Beck's triad is non-pulsatile elevated JVP. One of the highlights in Beck triad is in all cardiology conditions, you always get a pulsatile elevated JVP. The only scenario where you get a non-pulsatile elevated JVP is cardiac tamponade, and D is the answer to this question. Other features are anyway clear. Hypotension will be there, muffled heart sounds would be present. So he deliberately did not ask about muffled heart sounds and hypotension because that's gonna be like a walk in the park for you guys. Nothing big deal about it. He decided to ask about the first point that I've written, which is usually neglected. Non-pulsatile elevated JVP is what is saying there. And the logic for option number A is pulsus paradoxus initially is not present in cardiac tamponade. It takes some time for the pulsus paradoxus finding to appear in a patient. And another reason I can say is pulsus paradoxus may be missed by the doctor also. I mean, you have to check out now that the pulse is disappearing in the phase of inspiration. You have to check out the systolic and the diastolic blood pressure of a patient and the differences between them. And if I have not seen a patient like that earlier, there's a high probability I'll still miss it. But that does not mean that I miss the diagnosis altogether. The diagnosis can be picked up by echocardiography, can be picked up by the findings of obstructive shock that develop in this patient. The answer to 43 is Bombay. As I said, guys, answer is Delta. It's not Bombay because small sign is a feature of constrictive pericarditis. I mean, I still saw a comment where B came up. So I'm just reminding you once again that option number B is for constrictive pericarditis as discussed in the CRR mnemonic, constrictive pericarditis, RCM and right-sided heart failure. Okay, Ji, coming to 44, a patient has presented with cold intolerance, hypertension and slow ankle jerks. Cold intolerance and then slow ankle jerks, their features are hypothyroidism, and in this patient there is himself mentioned low T3, low T4 and TSH is elevated. TSH is something in the range of about 5.5 up to 5.5. Here it's 16. So this is a case of primary hypothyroidism. And for management of this patient, I'll start with levothyroxine 25 mics and then we'll gradually start increasing. Why I would not like to start at 100 microgram is considering the age of the patient. You know, lots of time, if I straight away start with 100 micrograms, then it will increase oxygen consumption of the heart and can trigger angina. Thyroid hormones can cause an upgrade of oxygen consumption of the heart. The upgrade of oxygen consumption of the heart can then cause development of angina in the patient. And since the age of the patient is 65 years, he might be having some atherosclerotic lesion in his coronary arteries. So I would not like my treatment to trigger or worsen his cardiac status, which is why I'm being cautious in this case. And I've decided to start it on the lower dosages and then gradually upgrade the amount of levothyroxine being given to a patient. Answer to 44 is A. We come to 45. A patient has classical endocrine question of, I mean, इसको कभी भूल ही नहीं सकते ना, PhD निमोनिक तो हमेशा ही आता ही है, palpitations है, hypertension है, diaphoresis है, that is always to be thought of in terms of pheochromocytoma. This tumor will be producing norepinephrine in about 80% of the cases. The tumor is gonna be diagnosed by ideally a 24-hour urinary fractionated metanephrine levels. What a couple of students of mine told me that this fractionated metanephrine was not in the options, and rather a test which used to be mentioned in the books earlier was given, that is VMA, that is vanillyl mandelic acid. So in case you are stuck between metanephrine and vanillyl mandelic acid, then first answer metanephrine levels. And in this question anyway, the answer is option number A, urinary metanephrine and VMA will help in diagnosis of pheochromocytoma. Please comment in the chat box, can we? No sir, similarly decrease abruptly. No sir, it's always a gradual. 25 से 50 करेंगे, 50 से ऐसे ही जाता है, 20, 55, 75, 88 भी होता है, 88 का भी टैबलेट आता है, then we go up to 100. Shubham says age preference is gonna be for all cases or in some specific cases. See, there are different ways of prescription. One of them is what I have said, start from a lower dose and titrate upwards. It is recommended to start from a lower dose always, because most patients who are having most patients who are having presence of hypothyroidism, they anyway have elevated cholesterol, so there can be a presence of atherosclerotic lesion in almost all the patients by the time diagnosis is made. So it's always advisable to be cautious and not cautious. I would suggest you to do it for all cases. Option B would be for option B would be for HIAA is for carcinoid tumor. Yes, Andrews, you're right. 44 is alpha. We come to 46. Okay, tell me the drug of choice for control of hypertension in pheochromocytoma quickly. I mean, we'll not give ABCD, will not be giving ACE inhibitor, beta blocker, calcium channel blocker, diuretics. What drug would be useful for management of hypertension in pheochromocytoma patients? Quickly, guys. Non-selective alpha blocker. I think I did not get it in the chat, but this is what you guys are saying. The drug that will be used is phenoxybenzamine. That's going to be a non-selective alpha blocker that we'll be using. Okay, sorted. We move to 46. So approaching the last 4 for today. Keep the focus on. 6-year-old kid has recurrent episodes of blinking fast and then staring continuously. तो blink कर रहा है फिर घूर रहा है. Episodes last 20 seconds with abrupt termination. There's poor performance at school. So the clinical presentation is in favor of absent seizures. Absent seizure will be associated with poor scholastic performance. The child will be unresponsive for few seconds, during which he may not be able to answer the teacher, and the teacher might think that he is trying to do it deliberately. So in these patients, the school grades would be falling. For management of absent seizures, the main drug that we'll be using so that we do not have a recurrence of the episodes would be sodium valproate. The correct answer for this particular question is option number A. Okay. Absent seizures are not the commonest type of seizures in children. If they ask you what is the overall commonest type of seizure in children, then your answer would be given as febrile seizures. Do not answer absence. And if they ask you which is the commonest one in neonates, then the answer will again change. For neonates, the answer would be given as subtle seizure. And if they ask you for adults, then it is GTCS. But if they ask you for neurocysticercosis, then it would be focal seizures. The commonest type of seizure, neurocysticercosis, is focal, child would be febrile, neonate would be subtle seizures. We are sorted with 46. Move on to 47. A young female has presented with feeling of weakness in the blinking of eye, diplopia and dysphagia. The symptoms are increased at the end of the day. I mean, neurology, whenever you are having diurnal variation of symptoms, it's always going to point towards myasthenia gravis in a patient. Please comment in the chat box presentation of Patterson-Kelly. Patterson-Kelly would be having upper esophageal web, because of which there would be a dysphagia. Along with that, you would be having iron deficiency anemia, and the changes in the nails that would be present, that is cholionicia. Because he had written dysphagia, that is why I thought I should mention regarding Patterson-Kelly in the question also. (47) we are sorted. 47 would be option number C. Yes, great. Febrile seizures, we use parenteral diazepam. Yes, for the episode, not for prevention. For prevention, we use oral diazepam or oral clobazam. For febrile seizures, for prevention, we'll be using oral diazepam, and for episode, we'll be using rectal diazepam. If in the exam he mentions intranasal midazolam, then intranasal midazolam should also be given a priority. Boerhaave-Andrews will cause subcutaneous emphysema, so that would be relatively. Scleroderma, in case it involves the lungs, the ACE inhibitors would be high. Focal seizure, carbamazepine, doc. Hitesh answered, asked for focal seizure. Carbamazepine and oxcarbazepine would be used. Then is the correct position, the sites of auscultation. He is asked about the anatomical position of the valves here. So, yes, guys, Hitesh, I've already answered for focal seizures. Yep. It would be aortic, then pulmonic. I mean, though the aortic valve is on the left, but then the positions would be ulta. I mean, aortic valve is left, but the best heard in the following areas. So it's all physicians should take money. That's the correct position for auscultation of all the valves. The correct answer for this would be option number B, aortic valve, pulmonic valve, all physicians should take money, right? I mean, it's all physicians take money. Yeah, and they should take money. There's nothing to be ashamed of. Okay, free service nahi karna. A patient has had a RTA, road traffic accident, GCS is 9 on 5, 8 would be coma, so it's pretty near that. There's no external bleeding that's visible. IV fluid resuscitation was done, but the patient is still hypotensive. So that tells us that he's not in hypovolemic shock. I mean, the language of the question tells us that there is a bleeding occurring somewhere because his BP is low, but it is not a hypovolemic shock in a patient. And he says which of the following is the least likely cause of this particular presentation. Okay. You see, if you look at, I mean, he's rather asking you in this question, he's rather asking you which is least likely a cause. So I don't need to get into obstructive shock, and I don't need to talk about tension pneumothorax and cardiac tamponade in a patient. If you look at hemothorax, splenic rupture, and retroperitoneal bleed, then all of these would be examples. I mean, all of these would be examples of hypovolemic shock. All of these that I've described before you are examples of hypovolemic shock. One possibility is that maybe our narrow bore cannula was used initially, or the amount of fluid that has been given is not substantial to cause an increase in blood pressure of the patient. So B, C and D are all hypovolemic shock. But if you look at option number A, there is a focal bleed in the brain of the patient. That does not cause a hypotension. In fact, if it's a subdural hematoma can cause subsequently a raised ICP, and that will cause a Cushing reflex, and Cushing reflex will be having rather a bradycardia with hypertension. So because he's asking least likely cause of hypotension in a patient, the correct answer for this would be option number A. Other options which are present, they are having a bleed, and if we give a IV, even if I give fluids, I mean, it's not that the BP will pick up immediately. But the concept behind the question is that option number A is a closed cavity bleed which is of limited amount, maybe 30, 40, 50 cc, मतलब और कितना, मतलब 70 कर लो, तो ब्रेन में तो ब्लीडिंग एक लिमिटेड अमाउंट का ही ब्लीडिंग हो सकता है, और वो जो ब्लीडिंग है वो रुक जाएगा बाय द tamponade effect, and then it will cause raised ICP, and because of raised ICP you will rather be having a Cushing reflex coming up, due to which the BP will be on the higher side and will not be relatively lesser. So the gist of the question is primarily that he wants to see that are you aware regarding the finding of Cushing reflex with respect to a subdural hematoma, in contrast to hypovolemic shock in the inferior ones. Okay guys, so we do the last one for today. I've had a good performance. I would like you to comment in the chat box subsequently, or you can do it now also. How many out of 50 did you get correct? And I think a decent score would be, because these are recent MCQs, previous ones, so I expect a score of at least 40 plus should be a decent one. Yeah, burhole, mannitol, burhole surgery. Burhole is not a definitive treatment. It's a decompressive hemicarinectomy that would be required. We are having a man with early satiety. There's pallor, there's chronic abdominal pain for 6 months, and the main word is the presence of so many cells, myelocytes, metamyelocytes, blasts present in a patient. So it's giving me a finding a shift to left, and every time I read about shift to left, it's gonna be chronic myeloid leukemia. So that would be a Philadelphia chromosome, that is 9:22. I got a A. 814 is for Burkitt's lymphoma. It would be a child Afro-American with a jaw swelling, and even the remaining options, I mean A, C and D, they're all for Burkitt's lymphoma. And the presentation is that of chronic myeloid leukemia, because there's a shift to left. Every time they give a question in which there is gonna be presentation of multiple immature cells, I would suggest you to get these words right, shift to left and immature cells present, that would be chronic myeloid leukemia as a diagnosis. We'll do a FISH/a PCR for confirming our diagnosis, and then the treatment of the patient can be started subsequently. Cutoff for blast crisis is not 20% anymore. Cutoff for blast crisis is 30%. So that's a slight update. And my suggestion is that for all the malignancies, when you go to the PrepLadder app in the medicine section, I would suggest you to invest. Though I know you've read that for pathology, but my suggestion would be that all the 4 cancers, invest half an hour into each of them, so that you would be in a better position to solve those questions, even if they are having a longish description. Like in this question, there was early satiety coming up. That's because of the splenomegaly pressing on the abdomen of this patient, and that would cause a early satiety to be developing in this patient. This would be my email ID. In case you are having a doubt, you can contact me. PCR being preferred, doc will prefer first a FISH and then a PCR in a patient to find the transcript copies. To check for molecular imaging, yeah, PCR would be preferred. But initially, I would prefer a FISH followed by a PCR to check up how many copies are present. Yes, if it is resistant, then bosutinib would be used. So just invest half an hour into those videos, and that would give you that additional firepower that is required for the actual exam. Do subscribe to the channel if you haven't. Do like the video if you haven't. And yep, I'm gonna see you again very soon in another session probably. So till then, keep the pressure on, and as I say always, I'll just bring the first slide onto your notice. Keep calm and keep hammering. That's the thing that is required. Ultimately, I mean, as doctors and would be doctors, I mean, you are gonna be handling a lot of pressure. There's a lot of negativity in our field. My job is I try to minimize the negativity every time I come online. So yeah, you have selected the right profession, and not everybody can be a doctor. I mean, it takes a lot of hard work, lot of dedication from within to give a part of yourself to save somebody's life. Even if you save one life in your entire lifetime, I'm saying, forget about being a very famous doctor. Even if you do something, that itself is big deal. I mean, people just post on social media, they want to change lives, they don't. But you guys are gonna be, changing people's lives, course of illnesses. So yep, you are doing the right thing, and keep on doing questions. Number of questions that you should be doing daily, in my opinion, should be at least 100 per day. Even if you are not on that particular day feeling like studying, just go through the questions, passively read the options there, and passively read the explanation and try to rule out the options as I have said here. And you would be in a better position to analyze the MCQs. I mean, not every day, you get up and you feel like, okay, I'm going to read this topic. So when fatigue sets in, just either listen to the live sessions or try to do MCQs. I would suggest, keep a book in front of you, try to read the explanations, try to read the questions, and try to do as many questions as you can do per day, and you are gonna do great. So yep guys, I'll be waiting for your comments. I mean, out of 50, whatever you got, I mean, be honest with yourself and try to change it after 15 days. If you're gonna follow my advice of 100 MCQs every day, you will notice that you are great Desh, great, good job. बट देन वही देखो कि यार क्यों गलत हुआ, वो 10 जो गलत हुआ वो क्यों हुआ, क्या जल्दबाजी में गलत हुआ या मुझे टॉपिक नहीं आता था, उसका एनालिसिस कर लेना, एंड आई थिंक दैट यू वुड बी able to manage great. So great Hassan, great Santosh. As I said, I mean, my advice is look at not the positive here, मतलब अच्छा है आपका स्कोर ठीक है, बट देन चेकआउट की जो गलत हुए वो क्यों हुए, क्योंकि वो तो मतलब रिपीट थे ना यार, तो मतलब सारे, मैं तो कह रहा हूँ 100% स्कोर करना था हमने. चलो ठीक है guys, God bless you, thank you so much for your patience and hearing me out. My email ID I'm saying again is marwahmedicine@gmail.com. So in case you have any queries, you're most welcome to let it know. And at PrepLadder we would try to make things much more simple for you guys. We will strive to give you the best of the data in the least possible amount of time, so that you get that edge and you are able to clear the exam in the very first attempt. You will get low Asif in GTs because GTs are deliberately made to be little difficult, वरना आप सीधा सिलेक्ट सिटी वॉक में जाके पार्टी करोगे साकेत में, जो कि मैं नहीं चाहता हूँ, इसलिए थोड़ा सा डिफिकल्ट रखते हैं, उसे डिसइल्यूजन नहीं होना है. वहां पे भी आपने वही देखना है कि यार देखो, अगर कोई बहुत रेयर टॉपिक था, सपोज सम रेयर सिंड्रोम इज आस्क्ड, जो आपने कभी पढ़ा ही नहीं, तो लेट इट गो ना, आई मीन दैट इज नॉट द कॉज ऑफ वरी. But suppose there was a question on road traffic accident and you had to select between fast and exploratory laparotomy, और आपने fast select किया, आंसर exploratory laparotomy था, या laparotomy select किया, आंसर fast था. तो वो मतलब देखना है ना कि यार एक blunt trauma, एक blunt trauma abdomen का केस आ रहा है, blunt abdominal trauma का, तो कहाँ पे आंसर करते हैं फास्ट, कहाँ पे करना है, कहाँ पे लेप्रोटमी करना है, क्रैशिंग पेशेंट है तब क्या करना है, कार्डियक टैम्पोनेड में क्या करना है, पीएसवीटी में क्या करना है. सो ऑल दोज एस्पेक्ट्स दैट यू गाइज आर वेरी मच फैमिलियर विद. द टॉपिक्स आर गोना बी सिंपल, पेपर इज गोना बी सिंपल. इट्स जस्ट दैट इन द प्रेशर पीपल टेंड टू मेस अप विद द ऑप्शंस. तो हाँ जी, हाँ जी, हाँ, वन लाइनर करेंगे विनोद, विल डू दैट. आज तो मेरा ऑब्जेक्टिव यही था कि भाई आपको एटलीस्ट थोड़ा टाइम पहले एक बार सेंसिटाइज करा दूं कि भाई पहले वाले जो क्वेश्चंस हैं दे शुड नेवर गो रॉन्ग. सो लाइव सेशन तो सर अभी मैं आई वाज एट पीजी का था सर, दैट वाज एट भुवनेश्वर. तो अब और तो कोई लाइव नहीं होगा, मतलब आई डिड कंडक्ट अ कपल फॉर एफएमजी आल्सो इन गौतम नगर, बट देन उसके बियॉन्ड तो नहीं है. सो थैंक यू गाइज, गॉड ब्लेस यू, टेक केयर, एंड इट वाज रियली नाइस इंटरेक्टिंग विद यू गाइज. बाय बाय, टेक केयर.